Jumeirah Dubai, who will be talking about continuous glucose monitoring, followed by an excellent session by Dr. Iyad Abuward on diabetes kidney disease. Dr. Iyad is a consultant nephrologist at Al Tadawi Specialty Hospital, Dubai. And the last talk will be by the UK speaker, Dr. Umar Mustafa, who is a consultant physician. I'll hand over to
everyone, and many thanks for allowing us to join this event. So basically, I think we try in the next 20 minutes to explain why CGM is very important in our practice. Globally, diabetics in numbers are on the rise. I think we're probably going to have problem lowering the number due to the large amount of pre-diabetic globally, the lifestyle we live in, and actually the large-scale prevention program will require a lot of effort and financial consideration, probably difficult to reach. Is it important to use technology? I think yes. Probably in this day and age, there's probably not much option not to use an advanced technology when it comes to the management of young type 1 diabetic and type 2 diabetics, particularly people using multiple insulin injection. But adaptation and when witnessed throughout the trials that excuse me, that the usage of CGM does improve outcome in type 1 diabetic, and it does improve patient reported outcomes. Patients seem to be more engaged when they get onto CGMs, and there's benefit in patients using insulin pumps or even AID systems. So, it's become a standard of care for glucose monitoring with patients with type 2 diabetes. And you can see this in the statement in 2026 by the American Diabetes Association. So it's something that's probably been imposed as a part of the guidelines. We can use it in non-insulin therapy. It's very important to use it in people using oral anti-hypoglycemic agent plus insulin, and even patients on. Now, if you look at the Diamond study, this is a trial with 158 patient adult type 2 diabetic patient with a median duration of diabetes for around 17 years, so a long duration of diabetes, receiving MDI of insulin plus minus oral hypoglycemic agent with a baseline A1C between 7.5 and 9.9. And the trial ran for 24 weeks, looking at A1C reduction between patient on CGM and patient on usual glucose monitoring. The outcome, what we can see here at the baseline, then at 12 weeks and 24 weeks, there's a better glycemic control in CGM group, around 1% mean reduction in A1C from baseline, with a 0.3 mean treatment group difference. And hypoglycemic events and quality of life was similar between groups, I think, because of the shorter duration. But certainly there was around 1% mean reduction in A1C, and we all know on the long term, if that is sustainable, what that means for term of microvascular complication in particular. If you look at the mobile study, that's for patients using basal insulin. So 175 type 2 diabetic patient on basal insulin without short-acting insulin plus oral hypoglycemic agent between men and women, average age 57, A1C at baseline 9.1%, CGM group, blood glucose monitoring, primary outcome was A1C reduction at 8 months. So slightly longer, and that's typically what we see in the clinic. So if you look at baseline and look at 8 months between the CGM and the usual blood glucose monitoring. So 1.1 mean reduction from HbA1c, minus 0.4% mean treatment group difference. Severe hypoglycemic events occurred in 1% in the CGM and 2% in the blood glucose group. So not much difference, but you can see again, for a longer duration, the A1C was much better in the CGM group. That's on type 2 diabetic on basal insulin, which you see in primary care, internal medicine, and diabetic clinic. Now, what's about type 2 on non-insulin anti-hypoglycemic therapy? That's the immediate trial. Here they looked at 116 patients, adults with type 2 diabetes on at least one oral hypoglycemic or non-insulin therapy. The average age was 58. The mean diabetes duration, 10 years, are probably acceptable not to be on insulin if they have a good control. But look at the A1C, 8.6. So looking at CGM versus usual standard of care for glucose monitoring, the primary outcome was the mean time in range in the final 2-week period measured by blinded CGM. And here you can see a better glycemic control in the CGM group, 10% mean treatment group difference. Total below range was low and not significantly different between two groups. Hypoglycemic events were few in both groups. The glucose monitoring satisfaction was actually higher in patients on CGM. So even for non-insulin therapy, it brings probably a better satisfaction when it comes to glucose monitoring, which is quite an important factor for the care of type 2 diabetic patients. What's about patient type 2 on MDI or basal insulin? And this is a real more retrospective 12-month analysis, okay, for 940,000 patients. Type 2 diabetic, 59% for women, the mean age was 49, and patients were taking either MDI or basal insulin. Now, if you look on the left-hand side, so change in all-cause hospitalization was in favor of CGM group, and changes in all-cause emergency room visit was again in favor of CGM. So both hospitalization and admission or presentation or visit to ER rooms was lower in patient using CGM group. So the benefit of CGM demonstrated across a wide range of patients with type 2 diabetes. Okay, so insulin adjustment isn't the only driver for CGM benefit in people with type 2 diabetes, right? Now, but as you can see, the payer support for CGM varies from one country to another. If you look at Spain, the CGM is only financed for patients with type 2 diabetes. CGM is financed for patients with type 2 under intensive insulin therapy. They have to be in a specialized center. But as we go in different places of the globe, like in the Gulf, for example, the payout is slightly higher. Now, the cost utility of CGM versus standard blood glucose monitoring in insulin-treated type 2 diabetic patient, that's the IQ via core diabetes model used to estimate the cost effectiveness between the two. So the CGM likely to be cost effective for patients with insulin-treated type 2 diabetic. This is data from Spain, and we can see that quality of life gain with CGM was better, and the incremental cost utility ratio was 2.506 per QLY, gain lower than willing to pay. So analysis projected a reduction in cumulative incidence of ophthalmic, renal, neurological, and cardiovascular event for those patients on CGM monitoring. If you look at the UK, the CGM is supported again for people with type 1 diabetes. Adults with type 2 who have an MDI injections and condition are disability, that means they cannot use capillary BGM blood glucose, then they are covered. Slightly different to what happens in other countries. If you look at Saudi Arabia, for example, there's a national guidance is lacking, and most payer out develop their own guidelines for eligibility. And similar to what we see in UAE, for particular insurance, it's pretty much a guidelines, straightforward coverage, but for other insurances are really depend on the policy, and this is where difficulty comes. What's about pregnancies? It's a very good question we get asked all the time by colleagues and by pregnant lady. CGM can certainly help to achieve glycemic control and A1C goal in type 1 and pregnancy, and may be beneficial for other type 2 diabetes pregnancy. Remember those patients who are a type 2 using insulin. I think for type 1 becomes standard of care. for pregnant ladies to be on CGM. Nevertheless, they will be probably on CGM prior to getting pregnant. And recommended CGM to prevent individual with type 1 diabetes, in conjunction with aim to achieve traditional pre- and postprandial glycemic control. And we know CGM can reduce the risk for gestational age infants and neonatal hypoglycemia in pregnancy complicated by type 1. That's certainly evident. That you can read that from the statement in the ADA. If you look at CGM pregnancy with gestational diabetes, this is an RCT, an open-label, single-center trial for pregnant women with gestational diabetes and above 20-week pregnancy, randomly assigned to CGM plus capillary blood glucose versus a CBG alone. And patients treated with CGM group had a significantly higher time in range. So that's what matters, right? When it comes to pregnancy, in particular, we don't rely much on A1C rather than fasting postprandial and glucose variability. Certainly, there is no significant adverse event reported between two study groups, and no significant differences in perinatal delivery for neonatal outcome between groups. But you can see, time up in range was higher, with the mean glucose was better in patients using the CGM. So, CGM improves detection of hyperglycemia and hypoglycemia in GDM. That's what the women and mothers, suffers from, and provides a better overall glycemic control and enhanced user satisfaction versus standard mean blood glucose. You all know how anxious mothers become when they see the differences in the blood sugar. So the current evidence is limited regarding the potential value of CGM versus standard mean blood glucose with respect to adverse pregnancy outcome. But certainly, it lowers maternal gestation weight gain, reduces the incidence of preeclampsia, of new onset hypertension with a proteinuria after 20 weeks of gestation, reduces preterm delivery, reduces large for gestation age or small for gestation age neonates, and reduce neonatal hypoglycemia or admission to neonatal intensive care units. But large longer-term studies are needed to address gap and better understanding of the practical implication and clinical impact, but that really shouldn't stop us from applying CGM technology as needed on the individual basis for gestational diabetes. But certainly, I think there's a notion to us, type 2 on MDI, certainly they'd be better off to be treated like a type 1 with CGM application. Potential barrier to CGM when you use it in type 2 diabetic patient. Cost is an issue, certainly because of the insurances, but I think the understanding of the CGM technology, remember, vast majority of type 2 diabetic patients, by the time they reach the needs for MDI or basal bolus regime, they're probably older in age, they're probably not very familiar with the technology, difficult to explain to them, how to manipulate with the mobile device or with the sensor readings, and how to try and navigate through the AGR report and report back to us. So those particular group will require more of an education and support with diabetes specialist nurses, and probably continuous communication with a younger member of the family. And patients often challenged to understand CGM technology, including availability, how it works, and rural care. The question I always get asked, how will this device measure my blood sugar? It's always important to explain to the patient three things. It's not blood. It's not similar to your finger stick. It uses interstitial fluid, but at the same time, it's a continuous reading. So you get more value for your money. You are actually getting your blood sugar checked by the second. And very important 2 points to explain. There will be discrepancy, particularly in the first 24 hours of the CGM application, or when you apply it to the patient. And certainly there will be some difference between capillary blood sugar in terms of readings and time. You have to explain to the patient they're probably not at the same time. This is capillary, this is interstitial, and when you have in the lab, it's probably the most accurate. But this is as close to reality as it could get in terms of CGM monitoring. Now, how do you kind of reassure the patient? So provide a simple structured education. That's why you need a diabetes educator in every hospital. They are a must. I have learned my diabetes from diabetes specialist nurses. They are the best to deal with the patient and patient needs, particularly when it comes to type 2 diabetic patient. Type 1, majority of them are young, very tech-oriented, and majority of them are, are very clever. Focus on trends, not on single reading. So explain to them, what we're looking for is the differences, the variation, okay? So don't worry about one reading, don't worry about it. And if you're not quite sure, or use your finger stick. If you're not feeling well, use your finger stick. And use the data review tools and use the AGI report, not from the mobile phone. Show them the screen, print it out. People still like to see and read, right? Particularly a capable type 2 diabetic. So always show them the screen from your PC, not from mobile phone. And if you can, because eventually you have to apply for the insurance to claim your money in the clinic if you work in insurance environment practice, that when you print the AGI report, you can show them pre and after adjustment if needed. The other potential is data overload and emotional burden. You get a type 2 diabetic patient into 4 injections of insulin, GLP-1, 2 oral hypoglycemic agent, GLP-2, an ACE inhibitor, an aspirin, and statin, another blood pressure, a B complex, a vitamin D, and God knows what else. It's a lot to put into the patient head in one visit, okay? Please give them time. Please allocate a certain clinic visit for the patient when it comes just for CGM. Do not do it at the same time of each consultation. You can ask them to come back after 2 weeks when the device loading has expired and sit them down and do not focus on other things. You have to remove that emotional burden and data overload from the head. So while CGM provides a valuable insight, it can also foster stress from constant numbers, shame or guilt around glucose spikes. They feel guilty because they see more, fear of being monitored all the time. They say, like, this is a spy. And some patients may stop with CGM for emotional reasons. So do not expect your patient to be continuously compliant with the CGM usage. But, to try and make it simple for them and show them, I always start, look, time in range is significantly good. Look, 65% versus 53 last time, and look, now it's 70%. So go to the positive side. Review the data positively as much as you can. Then you can actually break down the abnormal results like a hypos and variation after food, which even a non-diabetic, when you apply the CGM, will get. So you use your common sense to try and reassure patient in the clinic. Device wearability, now, the majority of them are small and they can stick into the skin without any problem. Skin irritation, you can use some adhesive allergies, and they will get some sense of discomfort, but you can always kind of reassure them that it's very unlikely to happen. And if it happens, we can use some sprays to avoid this irritation. For the sake of time, and I think we're just going to skip to the next one. Discrepancy, I explained to you about it, this interstitial fluid versus capillary, time is different. The first probably 12 to 16 hours from the device are not reliable, and maybe the last day, it depends on which sensor you're using. But, prepare the patient at the beginning. Look, the first day, don't rely on it much. It will, just say to them, it will take a bit of calibration to get into your interstitial fluid. There will be always a difference between two of them, but don't worry, use your finger stick if you feel unhappy, if you feel unwell, if you're feeling a hypo, if you see abnormal results on your sensor, and always call us back if you have any issue. And I must say, majority of the CGM company, they actually provide an excellent technical support as needed. We talk about discrepancy in between CGM reading and physical signs and symptoms. They may have abnormal 43 milligram per deciliter results on the CGM, and they feel very well. Always check from your finger prick as much as you can. CGM in type 2 diabetes, we started actually last week. I had somebody in casualty, very clever boy. He's actually doing AI first year in Dubai. I said, hi, how are you? He was very accepting that he's a type 1. I put the sensor after 15 minutes. He was teaching me about the sensor the next day on the ward as he's coming out from DKA, and he's so happy with it. So, age matters when it comes to technology. Bias among healthcare professionals can be a barrier. I think, probably age. I think age and gender are the main barrier. Sorry, age and insurance. Apologies. The payment by insurance could be denied, it's too expensive. And I think all the patient, unless they have an adult companion or a home nurse, they're probably going to find it difficult to adapt. But nevertheless, you have to find a way around implementing as needed. Type 2 diabetes, we talked about it, patients who have a poor control on basal insulin or MDI probably should be given a trial for a few weeks or months on CGM just to try and regulate the blood pressure, understand the variability, and explain to them differences in readings according to their treatment. You always use offer a CGM and use shared decision, make it to explore the option regarding value to barriers versus barrier to use. Not everybody will accept to use it. Okay, so how important to have a CGM? It reduces hypoglycemia, target medication decision, precise glucose pattern identification, and stronger patient engagement and better probably quality of life with their medication. For the sake of time, I'm just trying to. So CGM behavior, we have to use motivation, real-time feedback on glucose levels all the time, diet and exercise, medication feedback, how they can see the changes when they do sport, gymming, swimming on the CGM, and always use the positive reinforcement. Show them time and range. Do not be negative when you analyze the data. So in summary, CGM has consistently shown to enhance glycemic control, to reduce A1C, and improve outcomes in patients with type 1 and type 2. CGM has been a cornerstone of diabetes management in patients treated with insulin-based regimen, standard of care for all persons using any type of insulin, probably in the future. Expert recommendations support the use of CGM in people with type 2 and any type of anti-hyperglycemic therapy, not just insulin. And CGM helps clinicians and diabetic patients to improve glycemic control, reduce a glucose-related adverse event, and support behavior modification. With this, I would like to thank you so much for listening to me. Thank you.
Thank you so much, Dr. Osama, for your excellent talk on continuous glucose monitoring. And I can see there are lots of questions, so it was very engaging. I would now like to hand over to Dr. Ayad to talk about diabetes kidney disease. Dr. Ayad is a consultant nephrologist at Al Tadawi Hospital, Dubai. Over to you, Dr. Ayad.
Good morning, everyone. In the next 20 minutes, we will speak about the diabetic nephropathy, a very known problem. A problem because if we look in our chronic kidney disease patient, even patients with dialysis patient, with end-stage kidney disease patient, we will see that most of our patient who is receiving renal replacement therapy is because of diabetes. So in the next 20 minutes, we will try to understand the pathophysiology of this disease. I think that will help us to understand the treatment and how the treatment works, what is the new in the treatment of and prevention in chronic kidney disease due to diabetes. First, we will discuss the mechanism, the pathophysiology, the progression, what is happening in the kidney exactly in diabetic patient, then how we do the proper diagnosis of this problem, and then what is the therapeutical options that we have to deal with this problem. First, we know and we estimate that around 40% of the diabetic patient will develop some stage or some grade of diabetic nephropathy throughout their life. The kidney disease around globally, approximately around 30 to 40% of all diabetic will develop some grade, as I said, of the diabetic nephropathy, and around 50% or 55% of the patients who developed end-stage kidney disease is because of diabetic nephropathy. Speaking about clinical risk factors, there is some modifiable factors like the hyperglycemia and the systemic hypertension. Also, another factors like lifestyle, smoking, and dyslipidemia. Another factors that affect the evolution of diabetic nephropathy like genetic susceptibility, ethnicity, age, and duration of the diabetes also can affect the progression of the diabetic nephropathy. When we study our diabetic patients, we have to understand in which stage the patient is now. because some phases are silent. Like, for example, the first stage, the hyperfiltration, for sure in our patient in the consultation, we will see some patient who is long-standing diabetic and they have a normal kidney function, even they have low creatinine, that means high EGFR. This is the phase what we call hyperfiltration. The kidney start hyperfiltrating more. And after that comes the silent phase that the EGFR comes to normal. And in this phase, the damage in the structure of the glomerular basement membrane thickening starts. After that, when the damage happened and established, the microalbuminuria, means between 30 to 300 milligram per gram, starts. And after, when the disease progresses more, we go to the decline of EGFR and the macroalbuminuria phase. Understanding better the why this happens, and that explains to us why we give some of the medication. Now there is another two medication which is completely indicated in diabetic to prevent diabetic nephropathy. So understanding, I will go a little bit fast because this is long. When a patient is diabetic type 1 or type 2 and there is poor glycemic control, first we have to there is two pathways that lead to damage in the kidney. First, the increment of glucose load to the kidney that leads to increment of the proximal tubular absorption of sodium glucose through the via sodium glucose transporter, and this is one of the targets of some of the medication. This, through the mechanism in the distal tubules, activate the tubule-glomerular feedback in the macula densa, and that increase the intrarenal angiotensin II. This is why we have to understand why we have to give for diabetic patient to prevent when the diabetes happen. I mean, when the diabetic nephropathy happen, why you have to give SE inhibitors or ARB. When the intrarenal angiotensin increase, there is increment in the blood volume and the blood pressure and the blood perfusion, the renal perfusion, and that explains the initial glomerular hyperfiltration at the time of diagnosis. Then we have another pathway, which is when there is high and poor glycemic control, I mean high glycemia, that activate the advanced glycation end products, what we call AGE products, and increase the inflammation inside the kidney. We know that sugar is very related to the increment of inflammation, which lead to free radical production, which is oxidative stress, and liberation of cytokines and inflammatory mediators. This one leads to the mesangial matrix expansion and the formation of one of the pathognomic signs of the diabetic nephropathy, which is Klinefelter-Wilson lesion. At the same time, the presence of albuminuria due to the podocyte loss injury leads to the increment glomerular basement membrane permeability to protein, and this is the phase when there is a leak of protein, what we call microalbuminuria, starting with the microalbuminuria and then the macroalbuminuria, and that is playing the hemodynamic pathway. So both hemodynamic and metabolic pathway leads to damage in the kidney and destruction of the glomerular barrier and of the filtration, and finally lead to the diabetic nephropathy and loss of the kidney function. The histopathology in the biopsy, I mean, I understand the biopsy could be complicated even for me, but we have to understand there is three pathognomic structural changes, which is the first, Klinefelter-Wilson nodules, which is the one marked in the red arrow. Here I'm going to mark. This is like fibrosis inside the glomerulus, diffuse mesangial expansion. This is a loss of the barrier of filtration, and there is another hyaline damage, which is the capsular drop of fibrin cap. In the left side, in the upper left side here, we see the normal structure of the glomerulus. So here we can see the capillaries. I'm going to put markers in the capillaries, and then this is the space where the urine goes, okay, and leaves through the proximal tubules and turn from here to come to the distal tubules, okay? The blood goes through the afferent areola and comes out after the filtration through the efferent areola. And here we have the histopathology of normal glomerulus. On the other side here, we can see the fibrosis and the nodules formed inside the glomerulus that leads to the loss of functional matrix, functional structure of the kidney. Here also we can see the fibrin cap, and we can see the expansion and of the mesangial matrix and the loss of the structure of the glomerulus in diabetic patient. This is when we go to the pathological classification, we see in the class 1, GBM, glomerular basement membrane thickening, then class 2A, mild expansion of the mesangium, class 2B, severe mesangial expansion, class 3, the nodular sclerosis, and then class 4, when there is advanced glomerulosclerosis, and here started the loss of the filtration, the functional filtration of the kidney. So mainly there is 3 mechanisms that affect the kidney function in diabetic patient. GBM thickening, the podocyte loss that leads to leak of protein, and vascular hyalinosis that leads to the destroying the intrarenal vascularity and autoregularity capabilities of the glomerulus. How we make the diagnosis? If we go to the recommendation here in the presentation, I will put all the recommendation, the last updated recommendation. We have to assess the kidney function with random urine albumin to creatinine ratio. There is a big mistake. Some doctors, they do the microalbumin without the microalbumin creatinine ratio. But we have to do what is urine ACR, urine albumin creatinine ratio, to estimate the glomerular, and estimation of the filtration, EGFR, at least annually in people with type 1 diabetes with duration more than 5 years, because in type 1 diabetes, we know when the diabetes starts. But in type 2 diabetes, at the moment of diagnosis, we have to start screening, because type 2 diabetes, most of the patients, maybe they have diabetes years back and without diagnosis. In people with chronic kidney disease, we have to monitor urinary albumin and EGFR 1 to 4 times per year, depending on the stage of the kidney disease. So we have to use the spot urine albumin creatinine ratio, the EGFR, the calculated EGFR, and we have to repeat. Why we have to repeat? One time is not enough or is not accurate to make the diagnosis, because there is some physiological and pathological situation that also can give us microalbuminuria without having glomerular damage. Like, for example, high fever, high exposure to low temperature, or even high exposure to high temperature, exercise, and other conditions like maybe urinary infection or other type of things. So this is why we have to repeat 2 or 3 times over 3 to 6 months to make the correct diagnosis. When we see a patient with diabetes, long-standing diabetes, with diabetic nephropathy, we have to understand how is the pattern of diabetic nephropathy. We have a slow progression. We have a stable sediment. What is stable sediment? Understanding the urine is very important, because when we see the urine test, we see a lot of parameters. One of them is white blood cells in urine and red blood cells in urine. This is the sediment, or sometimes other things like casts in urine. We have to understand that normal sediment must be present in diabetic nephropathy. In diabetic patient with proteinuria. Only we have to see the proteinuria in diabetic patient to consider that it is diabetic nephropathy. If we see other parameters in the sediment, we have to consider other renal disease options. And in the ultrasound, it must be symmetric atrophy. Both kidneys are being affected at the same time. When we see that diabetic patient with duration, type 1, diabetic patient, less than 5 years, and without retinopathy, we have to think about other disease. When there is active urine sediment, also like red blood cells or casts, we have to consider other options. And when we see the rapid decline of EGFR, also we have to suspect other things, because diabetic patient, even with diabetic nephropathy, also can develop other kidney disease like IgA nephropathy or membranous nephropathy or any other disease that can lead to proteinuria. In KDIGO guideline, all of you knows about this table. I mean, the classification of EGFR, according to the EGFR, the classification of chronic kidney disease from G1 to grade 5, which is kidney failure, EGFR less than 15, and the classification for according to the albuminuria from A1, A2, and A3. In this table, we have to consider this when we need to decide just screening, or when we have to decide when start the treatment, or when we have to refer to the nephrologist. Pharmacology of the diabetic. First, I will speak about the prevention, and then we will go when the chronic kidney disease is established. Very important, the metabolic control in type 2 diabetes. We have to treat patients with type 2 diabetes and chronic kidney disease with sodium glucose cotransporter 2 inhibitor, SGL2 inhibitors. And we have to add additional glucose lowering therapy if glycemic control remain inadequate. We know that the diabetic nephropathy is mainly because of the high glycemia. So it is important first to work in the metabolic control. Second, GLP-1 receptor agonist. We have to use GLP-1 when additional therapy is required. The benefit includes cardiovascular protection, reduction in kidney disease progression, and weight loss and control, glucose control. Blood pressure management, very important, and maybe we know about the last update in the AHA guideline regarding the blood pressure. Here in the last update about diabetic nephropathy, we have to have systolic blood pressure below 130 when tolerated, otherwise below 140. And in all patients with diabetes and hypertension, we have to start ACE inhibitors or ARB. I mean, we have to block the angiotensin. Steroidal mineralocorticoids receptor antagonist may be useful in selected patients. And we have to avoid the combining an ACE inhibitor with ARB or aliskiren. Preventing the progression of chronic kidney disease using SGLT inhibitors when kidney function is more than 20 milliliter, the clearance is more than 20 milliliter per minute per 1.7, I mean the EGFR more than 20, we have to consider the SGLT. Preventing, we'll go a little bit fast because we are out of time. We use the maximum tolerated dose of angiotensin. I mean, don't worry about, sometimes we are worried about that the ACE inhibitors that can decrease the EGFR. In the last update, in the last guideline update, we can accept even reduction in the EGFR 30% if we can get the benefit of the preventing, I mean, developing the diabetic nephropathy. So we have to use the maximum tolerated dose of ACE inhibitors or ARB. We have to use GLP-1 agonist in patients with persistent albuminuria, not only for the weight, because a lot of people that consider it just for weight loss or glycemic control. Also, it is useful for proteinuria. We have to consider the non-steroidal mineralocorticoids receptor antagonist in eligible patient to treat the albuminuria and diabetic patient. And we have to maintain that protein intake between 0.6 and 0.8 gram per kilogram daily. Regarding the treatment, additional treatment like antiplatelet and anticoagulant therapy as a secondary prevention, not a primary prevention, we can use a low-dose aspirin in patients with established atherosclerotic cardiovascular disease and using dual antiplatelet therapy after acute coronary syndrome or coronary intervention followed by individualized long-term therapy. Also, we can use long-term antiplatelet therapy after a previous non-cardioembolic ischemic stroke or transient ischemic attack. Consider a short-term dual antiplatelet therapy after acute non-cardioembolic ischemic stroke or transient ischemic attack. Do not prescribe a low-dose aspirin for primary prevention because benefit-risk balance is uncertain. This is the one I want you to know that, because the practice before was to prescribe aspirin for all patients. So, summary, we have to go for the first-line treatment in patient with diabetes and start developing diabetic nephropathy or diabetes and hypertension, the RAS blockers, ACE or ARB inhibitor, decrease the progression to overt proteinuria and chronic renal disease by 22% in long-term cohort. The second line, the first line, the second medication, SGLT inhibitors, not only help to reduce the, help with the glycemic control, also helps with the prevention in the proteinuria and the prevention of progression of chronic kidney disease. Now, another new treatment, a new indication, the non-steroidal mineralocorticoid, finerenone. It shows a very good results in the treatment of proteinuria in diabetic nephropathy, especially type 2 diabetic nephropathy. The GLP-1 receptor agonist also as a treatment to prevent the proteinuria and the progression of chronic kidney disease. Here I will go very fast. This is other recommendation when it is established, the chronic kidney disease is established. One thing is important, we have to consider the protein intake in patients with chronic kidney disease and in dialysis, 1 to 1.2 gram per kilogram per day, because the patient in dialysis lose a lot of protein during the treatment. In pre-dialysis, we have to go, with proteinuria, we have to go for 0.8 gram per kilogram per daily. Okay. Another recommendation, it is similar, like in the prevention of diabetic nephropathy, but we have to go for one recommendation, which is the use of SGLT1 can be used with EGFR more than 20, and we will continue until the kidney fail. Okay. Then mineralocorticoid will go fast because it's the same recommendation before the chronic kidney disease and after the occurrence of chronic kidney disease. So the last recommendation in the combination therapy consideration for the optimization of kidney and cardiovascular risk reduction, we have to start initiation of an SGLT inhibitor and non-steroidal MRA, like finerenone, can be considered in adults with type 2 diabetes and urine albumin more than 100 milligram per gram with EGFR between 30 to 90. In this patient, especially when we start non-steroidal anti-inflammatory, mineralocorticoids receptor antagonist, we have to monitor the potassium level in the first month of the treatment, okay, because it can elevate the potassium. Also, it happened with the AC inhibitors and ARB. We have to monitor not only the decline of EGFR if it happened, also the level of potassium. And we have to take into our account that AC inhibitor and ARB is not allowed in pregnant patients with chronic kidney disease. When we have to refer to the nephrologist, individual should be referred to for evaluation by nephrologist if they have a rapid increasing in urinary albumin creatinine levels or rapid decreasing of the EGFR. Okay, and if the EGFR is less than 30, must be also referred to nephrology. So, summarizing very fast, we have to work in other, we have to work first in lifestyle. All patients with risk of developing diabetic nephropathy, they have to receive RAS inhibitors up to the maximum tolerated dose. And be careful, we cannot treat a patient with diabetes without proteinuria, type 2 diabetes without proteinuria and without hypertension. We cannot start as a preventing RAS therapy, because this is one common error. If there is no hypertension, no proteinuria, no need to start RAS inhibitors, SE or ARB. this is important to change. There is now another agent under study, after understanding the mechanism of the diabetic nephropathy. Now there is another medication under study, and some of them even in phase 2 trials to decide working on the fibrosis and other mechanism of diabetic nephropathy. How is the diabetic nephropathy is being developed? I think in the few second 2 years, more medication will be in the market for this type of treatment. And thank you very much for your listening. Thank you.
Thank you so much, Dr. Iyad, for a thought-provoking presentation about diabetes kidney disease. And I can see there are lots of questions, so it was very engaging again. I will now hand over to our UK speaker, Dr. Umar Mustafa, who is a consultant physician in diabetes and endocrinology at King's College Hospital, and he's a senior clinical lecturer at King's College London. He's also the Royal College of Physicians Registrar. We are honored to have you, Dr. Umar. You'll be talking about new treatment algorithms. Over to you.
Thank you very much. Thank you very much. Good morning. So I'll be bringing together all the what to do and the how to approach people with diabetes using treatment algorithms in whatever is available to us. Those are my disclosures. Definitions are key. So guidelines are basically rules or principles to guide us to do something, whether it's policy interpretation, providing care, etc. Whereas algorithms tend to do the step-by-step guides to whatever you want to reach. The definition of diabetes has not really changed in decades. Our understanding of diabetes is evolving fast. For example, in type 1 diabetes, the left shift towards pre-diagnosis is getting more and more, and certainly treatments are getting more. As it's for type 2 diabetes, this is a very old slide, but there is a lot more treatments now to prevent that progression and complications, which I'll come to. The criteria has not really evolved much, but of course we can now use HbA1c, and that's again in the last probably decade or so. The global stats are evolving fast. Life expectancy over the last 2 centuries have evolved in a very different direction towards better. However, diabetes prevalence and mortality is going in the wrong direction, despite our better improvement of treatments. And in particular, there are some areas around the world. So, for example, if we take the Middle East, there's a fast progression, fast annual percentage change in the prevalence. That affects countries in different ways, as you can see from this slide, and also the share of non-communicable disease globally, diabetes being one of the major ones, is also different in different populations. We can't go without talking about money. Health insurance around the world is very variable, and how we provide care is very variable, so worth bearing that in mind when we make our decisions to improve access to treatments. Treatments are getting more and more, so compared to decades ago where we had not much, now we have a lot. Also, the pattern of conditions are changing, so multiple long-term conditions is the norm, where 2 or more conditions in an individual. It tend to affect a musculoskeletal and a cardiometabolic. Those tend to be the common pairs. It affects people whether they are in most deprived or most affluent. This is data from England on combinations of multimorbidity. We see the same pattern in combinations of physical and mental health. Again, it affects you whether you are rich or poor, but of course, if you're in a more affluent area, you tend to have less compared to people in most deprived area. Again, this is data from England. I'll talk about what determinants of health and when I talk about the algorithms, but this is heavily featured in whatever we do. This is not just about the individual, but what is surrounding them in their life as well. So algorithms. I'll go through NICE guidelines. So NICE is a body in the UK that sets national guidelines for implementation for better outcomes at better cost. And there are some core principles in here that, for example, I'll go through the type 2, which is mainly what I'm going to cover. Type 2 updated earlier this year. It talks about involving patients. There's more individualized approach in this guidance, diet and healthy living being a cornerstone of interventions. And when choosing medications, there's now a specific way of looking at it and moving away from glucose focus to an outcome focus. There is also emphasis on providing effective sick days rules, as well as regular review and starting with metformin. It talks about starting sequentially rather than simultaneously, and also moving to the next step when they're going all the way up to the maximum tolerated dose. In symptomatic hyperglycemia, where people, for example, have nighttime polyuria, polydipsia, or daytime weight loss, insulin should be considered first. Question whether sulfonylurea should be in here given the glucotoxicity, and also a safety first approach when considering people with multimorbidity. And I'll take you through assessing the cardiovascular status and frailty. This is the algorithm, which is very different to what we used to have, which is glucose stepladder approach. Now it talks about different categories of conditions. And if you start from the left, where there are no relevant comorbidities, the first lines tend to focus on medications that have an impact, i.e. Starting with metformin and SGLT2 inhibitors and escalating that upwards to GLP-1s, insulin where relevant. For example, in obesity, the aim would be on weight loss. In CKD would be prevention of progression of CKD, chronic kidney disease. In early onset, there is a focus on preventing early complications. As we know, early onset type 2 diabetes before the age of 40 tends to have more of an aggressive profile with worse complications. In heart failure, the focus on cardiovascular outcomes and prevention of hospitalizations from heart failure, as well as managing the diabetes, because we know the heart is one of the components. It can be affected in type 2 diabetes and insulin resistance. Focus again on cardiovascular prevention. Frailty is key, I guess, to assess, I think should be assessed in all patients, particularly those with multiple long-term conditions, to adjust the glycemic targets and prevention and the heart failure. And as you can see on the right-hand side is things are much better. Huge link between diabetes and depression, something to be aware of. And therefore, I really want to hopefully provide you with a framework to maintain focus and empower individuals with diabetes in decision making, measure what matters to them, work for what matters to them, and for what matters biologically and clinically to us. Gather a team, ensure you use latest evidence. It's not all about glucose. A mind and body approach is really important. Think about the wider determinants of health around the patients. This is not just about glucose. And multidisciplinary care is really key, and avoid working in silos. Thank you.
Thank you very much, Dr. Mustafa, and thank you for all of our speakers. We had many questions, which reflects how interesting and engaging the three talks have been. I'd like to invite all of our speakers to join us for Q&A and panel. I had some challenges to filter through. There's so many questions that we had, so I'll try and pick some of the relevant questions. And I'll start with a question for Dr. Barakat. Someone is asking, can CGM significantly reduce rate of hypoglycemia in elderly patients? Dr. Barakat, if you can elaborate on that, please. Have you lost Dr. Usama? Okay, whilst he's joining, I've got a question for Dr. Mustafa. I found the 3 C's concept very interesting and something I'm definitely going to be using in my clinical practice, but also leads me to one of the questions from the audience. Someone is asking, how should physicians approach diabetes management in younger adults differently?
Well, most certainly. Again, it's about what matters to them, because we often, I mean, I don't do young adults, but I do see them when they get transferred. And I think one of the key things, speaking to colleagues who do this, it's about engaging with the individual. This is not about what is important for us. It's about what's important for them in that phase of their life. So it may not, and also it's about a staged small steps towards an agreed outcome.
Thank you very much, Omar. Dr. Abu, someone is asking about the use of ACE inhibitors and the increase in creatine clearance. Someone's saying, if creatine clearance increased by 25%, do we stop or do we continue? I think this is a worrisome area for many people.
Yeah, I just answered individually, and I was answering the questions. We can accept, I mean, as per guideline, we can accept up to 30% of decline. Of course, we have to monitor to see that there is no progressive decline. Okay, we are going for more. The benefit that we can get from the use of ACE inhibitors or ARB is more than the risk of the decline, and up to 30% we can accept.
Thank you very much. Another question to Dr. Mustafa. You touched on the mental health towards the end of your presentation. As part of your MDT, can you, for example, explain how important psychology in diabetes for patient care? And have you observed any long-term positive outcomes?
Of course, really important, and we're very fortunate to have good links with colleagues in mental health services in our team and in the locality. So it's important to, first of all, get your diagnosis right. So what are you dealing with? So, for example, we all talk about our metabolic control, etc. And I think it's important also to get the diagnosis right, whether you're dealing with depression, anxiety, etc. And then through that, work through what is needed. So, for example, somebody with multiple treatment, multiple insulin injections, treatment burden, heightened anxiety from that treatment, is important to whether it's possible to simplify that treatment, address that anxiety of what. So, for example, in type 1 diabetes, we see a lot of people who have anxiety about going low. So hypoglycemia fear. Those who other ones may have fear of complications, and how do you address that? How do you work this through? And then once you get the diagnosis, that gets referred, for example, to psychology, who will start to come up with a program of engaging with those individuals to improve that. The other side of the story, of course, is in those with when the psychiatry diagnosis impacts on the treatments that you do. So, for example, in those with severe mental illness, schizophrenia, bipolar disorders, some of the treatments may cause more metabolic adverse outcomes in terms of hyperglycemia. And how do you weigh that against the treatments you provide, and how do you simplify that? So again, it's about working with colleagues in other teams to reach the outcome best for the patient, as discussed and as agreed with the patients.
Thank you very much. Dr. Barakat has joined us again. Dr. Osama, someone is asking about the use of CGM to reduce significant hypoglycemia in elderly, and also leading to another question about time in range targets, and would you prioritize in your practice HbA1c or time in range?
Okay, well, I'll get into the second one. See, we don't rely on HbA1c quite often. Simply, the pharmacotherapy of diabetes and dynamic have changed quite a lot, right? I think we've been selfish. We used HbA1c in the past because it had nothing else to do, right? And diabetes was very simple. Now we know from all these long-term trials, it isn't about HbA1c. I think glucose exertion and variability, glucose variability is more important, particularly when it comes like pregnancy as well. Postprandial glucose is more important to outcomes. So I would take, for me, in particularly people on multiple insulin injection type 1 and type 2 patient, I would take time in range and average glucose, daily average glucose as a marker, certainly alongside HbA1c. The issue with HbA1c, and particularly when you work in the Gulf, that people seem to be shopping around. They go to different clinics and they've done HbA1c every 4 to 6 weeks, and you actually get stuck. Like, you can't do much about it. They go, particularly in Dubai, they will have the HbA1c today. They will have it later in 7 days. It's patient power, patient persistence, insurance and physician greediness. I'm so sorry. Yeah. So you get stuck with, sometimes you get 5 HbA1c in 3 months and you don't know what to do with them. So I think we've been privileged to have the technology and of CGM, which is, for me, is more reassuring pattern of practice. In the other one, sorry, what was the question about elderly and hypoglycemia, right?
Yes, role of CGM to reduce significant hypoglycemia.
I think it's like anything else, and it depends. I think before you get into CGM, you have to understand the dynamics of elderly, right? The first common things for hypoglycemia in those patient group is the impaired renal function. Number 2, injection sites, you have to check them. Make sure they change the needle every time. That's the hypertrophy is a major cause for poor control and hypoglycemia. Poor oral intake. Then certainly you can use the CGM, but the problems with the elderly, they're not going to stick to CGM, right? They're not going to like it. So I think, take your kind of practice, go to UK-based thinking of practicing medicine, yeah? Go to basic. Make sure they're eating well, elderly, no oral thrush, no dysphagia and gastric reflux. They're not renally impaired. The injection side is fine. They change the needle. Do you need to reduce the injection? Use a good basal insulin like Tresiba, when you can give it Diglo, that you give it early, or to Geo, you can give it early before, many hours before bedtime. Then if you're really stuck, not able to interpret the events, then you can use a CGM. That's for sure.
Thank you very much. I think we have run out of time. We just reached the end of our very interesting and refreshing session of the morning. Thank you very much to all of our speakers and to the audience. Many questions have come through, and probably we can link you to our speakers for to try and answer these questions at some stage. Thanks to Rahad for co-chairing the session with me today, and to the organizing team. I would like to ask the audience to move to the next session, which I think is a sponsored symposium, and we'll see you later. Thank you very much.
Thank you.
Thank you.
Thank you. Thank you.
يختلف هذا لأنه هو مش حاسس إنه حاله، هذا دليل إنه هو مش حاسس حاله مسيطر ولا بتمادى ولا، يعني هو بالآخر يعني كيف هو مش رجعتوش حالته طبيعي، ماشي ما رجعته طبيعي، وبالتالي هو مش عارف إيش يعمل. انتوا هالكلمتين حفظوني ببيتوا أخوك وأمك وحبسوني وخلص، بقيت المفروض ما يأثر فيك الكلام، هو إيش بيه نفس الحكي، بضيف إشي جديد. ألو
شو نسوي؟
إيش بقول إيش يعني ماشي أخوك جواد وأمك شرموط، إيش قال لك كذا؟ ما بديش كمان ولا ولا شيء، هي مسنود ما تفكر فيه، هذا بجوز حركات أخي ماشي حدا ما أحكي ولا إحنا مثلا قاعدوا الحق أقول لك
Obesity is not just rising, it's driving over 200 complications. In 2022, 2.5 billion adults were living with overweight, including 890 million adults with obesity. Acting now could help prevent this number from reaching 1.5 billion by 2035, as projected by the World Obesity Federation. Obesity is often seen as a matter of willpower, when in fact it's a chronic multifactorial disease influenced by sociocultural, environmental, epigenetic, genetic, biological and behavioural factors. Misunderstanding obesity leads to labelling people as lazy, fueling weight stigma and delaying care. Avoiding or delaying healthcare can cause obesity-related complications to remain undiagnosed, worsen and become increasingly difficult to address. By the time individuals talk to their doctor, 82% already have at least one obesity-related complication. It is well known that obesity-related complications are driven by adipocyte dysfunction. Healthy individuals display normal adipocytes, but in people with overweight or obesity, adipocytes increase in size and number. This contributes to accumulation of lipids in ectopic and visceral fat depots, which can lead to local and systemic inflammation and insulin resistance. Obesity-related complications are highly interconnected, with the presence of one disease increasing the risk of developing another. Let's take a closer look at some of them. Cardiovascular disease complication. Excess adiposity results in neurohormonal dysregulation, increasing the risk of all forms of cardiovascular disease and cardiovascular risk factors. Obesity increases the incidence of myocardial infarction by 2 to 4% and the risk of heart failure by 5 to 7% with each unit increase in BMI, and each 10 kilogram weight increase is associated with hypertension, with a mean of 3 and 2 millimeters of mercury increase in systolic and diastolic blood pressure, respectively. Obstructive sleep apnea complication. There's a bidirectional relationship between obesity and OSA, and fat deposits in the upper airway and thorax may worsen OSA. 60 to 90% of people with OSA have a BMI of 25 kilograms per square meters or higher. OSA disrupts appetite-regulating hormones and sleep, leading to reduced physical activity, contributing to weight gain and difficulty in losing weight. Metabolic dysfunction-associated steatotic liver disease complication. Excessive accumulation of lipids in the liver triggers several mechanisms that contribute to metabolic dysfunction. 88.7% of patients with metabolic dysfunction-associated steatotic liver disease are also living with overweight or obesity. Polycystic ovary syndrome complication. Approximately 1 in 2 women with PCOS is living with overweight or obesity. A vicious cycle that exacerbates both conditions occurs because PCOS may predispose women to weight gain, and obesity exacerbates PCOS. Type 2 diabetes complication. 90% of adults with type 2 diabetes are living with overweight or obesity. Each 5 kilograms per square meters increase in BMI increases the risk of type 2 diabetes complications, leading to an increased risk of microvascular complications by 21%, kidney disease by 39%, and neuropathy by 12%. Obesity may be complex, but it's also modifiable. Diagnosing and managing it with urgency and achieving weight reduction of more than or equal to 5 to 15% may improve symptoms associated with many obesity-related complications. The more weight lost, the greater the potential benefits. Today, guidelines recommend holistic management plans that are suited to individual needs. Appropriate interventions in combination with lifestyle changes can significantly improve the likelihood of successful long-term weight management. We hope this video has inspired you to start conversations with your patients to enable timely interventions, prevent complications, improve lives, and reshape the future of obesity care. Millions of people with obesity face not only impaired health, but also substantial bias and stigma. 890 million adults were living with obesity worldwide in 2022, yet studies show that 54% of people with obesity discussed their weight with their healthcare professional in the past 5 years. 36% were diagnosed with obesity, and 21% were offered a follow-up appointment or call after their last scheduled visit. Why does this happen? Obesity is a complex, chronic, progressive and relapsing disease requiring long-term management. So why isn't it treated like one? Often, the answer lies in weight stigma, which stems from the traditional belief that weight can be managed simply by eating less and moving more. However, science tells a different story. Obesity has multifactorial origins, including biological, epigenetic, genetic, environmental, behavioral, and sociocultural factors. Still, people with obesity encounter stigma almost everywhere, with 88% reporting being stigmatized due to their weight. These individuals experience stigma approximately 1 to 6 times per week, which can have severe and lasting physical and psychological consequences. It lowers their confidence to lose weight and increases their risk of depression and anxiety. In addition, it leads to avoidance of physical activity, negatively impacts eating patterns, and increases their risk of health issues such as cardiovascular disease, diabetes, and stroke. Fear of stigmatization has led people with obesity to avoid or delay healthcare. Individuals usually wait 6 years globally and 9 years in the UK before discussing their health with their healthcare professional. By the time they talk to their doctor, 82% already have at least one obesity-related complication. Avoiding or delaying healthcare can cause obesity-related complications to remain undiagnosed, worsen, and become increasingly difficult to address. The good news is that compassionate and non-stigmatizing obesity-related communication can make patients feel more comfortable, so they will ask for help. Even small gestures, such as maintaining eye contact, not avoiding appropriate physical touch, offering appropriate weight management advice when asked, and ensuring equipment fits all body sizes can help people feel valued, respected, and empowered. Healthcare professionals play a key role in this shift. Creating a supportive environment starts with 3 simple principles: recognize, communicate, listen. Recognize the impact of weight stigma on mental and physical health. Communicate that obesity is a complex chronic disease using respectful, person-first language. And listen. Acknowledge your patient's past experiences with empathy and care. By engaging in proactive and non-stigmatizing conversations, we can pave the way for timely interventions needed for obesity care. Diagnosing and treating it with urgency may prevent or reduce the risk of some obesity-related complications. Multidisciplinary and compassionate care can lead to timely interventions that reduce the impact of these complications. Weight reduction of more than or equal to 5 to 15% may improve or prevent significant obesity-related complications such as hypertension, type 2 diabetes, sleep apnea, metabolic dysfunction-associated steatohepatitis, polycystic ovary syndrome, and more. While appropriate interventions, in combination with lifestyle changes, can significantly improve the likelihood of successful long-term weight management, many eligible adults with overweight and obesity are not being managed with clinical interventions. Updated guidelines now provide clearer recommendations on how to manage obesity. Overcoming weight stigma could be the first step toward better health for people living with this disease. To recap, weight stigma delays care and can stand in the way of timely intervention. By combining compassionate, evidence-based care, we can help people with obesity achieve and sustain better health outcomes.
When initially diagnosed, type 2 diabetes is mild in many cases, so I can achieve good results with just diet and exercise. And by doing so, I can set patients up for success. Well, I think that this is a myth, because diet and exercise alone, despite being for sure an essential part of diabetes treatment, they hardly achieve good and sustained results by themselves in the vast majority of patients. In fact, less than 25% of patients treated so maintain a good glycemic control, even an intensive intervention. And we have to take in mind also that many of these patients have been struggling with obesity years before diabetes onset. So it doesn't really seem easy for them to follow these lifestyle recommendations. Well, for sure that it is really important to offer patients advice regarding healthy lifestyle habits. But I would say that even more important is to offer patients efficient tools like early pharmacological intervention that for sure will help them achieving weight and glycemic targets, and above all, will ensure a tight, early and sustained glycemic control. The UK PDS study showed that an early pharmacological intervention, regardless of the drug class used, as compared to lifestyle modification as the unique therapy, resulted in a better initial glycemic control that was associated to better microvascular outcomes. Additionally, this on the long term can come from a metabolic legacy effect based upon these differences in HbA1c attained during the first years of diabetes. This would translate into a reduced micro and also macrovascular risk of events that has lasted through years, even in the case of higher HbA1c values. HbA1c targets below 7% are generally recommended by most guidelines. So having patients close to that number is good enough to keep type 2 diabetes under control and prevent its progression. Well, this is clearly a myth, because it represents the usual dilemma between suboptimal control and treatment intensification as one of the phases of therapeutic inertia. Such approach, especially at the beginning of the disease, places patients at a higher risk for worsening of glycemia in shorter periods of time and at increased risk for micro and macrovascular complications on the long run. Well, the DISCOVER study is a good example of how delayed treatment intensification causes missed opportunities for early glycemic control and its related benefits. In this study, we saw how in different parts of the world, initiation of second-line treatment takes way longer than recommended, at occasions up to 4 to close to 7 years after diagnosis, and the average HbA1c is well above 8% before starting this intensification. Well, the diabetes and aging study represents a recent evidence that supports the metabolic legacy effect that was proposed after the UK PDS trial, but adding an important concept: stringent metabolic control, as low as 6.5% or lower, attained as soon as 1 year after diagnosis, had an independent impact on reducing the 10-year risk for macro and microvascular complications as compared to suboptimal glycemic control.
Obesity is not just rising, it's driving over 200 complications. In 2022, 2.5 billion adults were living with overweight, including 890 million adults with obesity. Acting now could help prevent this number from reaching 1.5 billion by 2035, as projected by the World Obesity Federation. Obesity is often seen as a matter of willpower, when in fact it's a chronic multifactorial disease.
HbA1c targets below 7% are generally recommended by most guidelines. So having patients close to that number is good enough to keep type 2 diabetes under control and prevent its progression. Well, this is clearly a myth, because it represents the usual dilemma between suboptimal control and treatment intensification as one of the phases of therapeutic inertia. Such approach, especially at the beginning of the disease, places patients at a higher risk for worsening of glycemia in shorter periods of time and at increased risk for micro and macrovascular complications on the long run. Well, the DISCOVER study is a good example of how delayed treatment intensification causes missed opportunities for early glycemic control and its related benefits. In this study, we saw how in different parts of the world, initiation of second-line treatment takes way longer than recommended, at occasions up to 4 to close to 7 years after diagnosis, and the average HbA1c is well above 8% before starting this intensification. Well, the diabetes and aging study represents a recent evidence that supports the metabolic legacy effect that was proposed after the UK PDS trial, but adding an important concept: stringent metabolic control, as low as 6.5% or lower, attained as soon as 1 year after diagnosis, had an independent impact on reducing the 10-year risk for macro and microvascular complications as compared to suboptimal glycemic control. When initially diagnosed, type 2 diabetes is mild in many cases, so I can achieve good results with just diet and exercise, and by doing so, I can set patients up for success. Well, I think that this is a myth, because diet and exercise alone, despite being for sure an essential part of diabetes treatment, they hardly achieve good and sustained results by themselves in the vast majority.
For a long time, 18 years or so. So despite all the treatment, glucose control continued to be an issue. And even if you look at the percentage of the patient that they're not able to achieve 8% or 9%, so you can see the dark black is over 8%, the light gray is over 9%. It's not better, it's actually maybe a little bit worse. So there is less of a control as the time passed, despite all the treatment and technology. Now, when we try to address the diabetes treatment, we have to remember that if we follow the ADA guidelines, we have to remember that we look at two things. So we have to look at the cardiovascular and kidney risk protection. We're going to touch on that a little bit later. And we're going to look at glucose lowering effect. And when you look at glucose lowering effect, you have treatments that are very high effectiveness, such as high-dose dulaglutide, semaglutide, tirzepatide. But also, you have the high-efficacy group, which is the metformin, the pioglitazone, the SGLT2, and the GLP-1, like, liraglutide or so. So, still metformin is a high and effective drug. But it has to be done correctly, and I'll show you that. So, the ADA itself will tell you can use metformin, except if the baseline A1C above 1.5% of your target. So if your target is 7, if you're above 1.5, so 8.5, you're going to look at combination therapy out of the batch. But again, it is an appropriate initial treatment to do because it is high effective. It doesn't cause low glucose. It doesn't cause weight gain. It may cause some weight loss. There are possible benefits on the cardiovascular. I'll show you the data. Neutral benefit on the kidney. There's even data showing benefit on the metformin and the arrhythmia, but again, this is beside the point. But of course, if you have a GFR below 30, you cannot use the medication. But again, it goes back to the point that it has to be done correctly and avoid any adverse event. So how do we do that? And I'll go over the metformin XR or the glucophage XR, but we need to treat the correct way. So this is an old data from 1997 by Garber and al. And when try to use the glucophage at a 500 milligram dose, 1000 milligram daily dose, 1500, 2000, 2500, you can see very clearly that with the 500, they had only 0.8% reduction, but when you go to the 2000, you have 2% reduction. What does that mean? If a patient comes to you with an A1C of 8%, for example, don't start 500 and bring them back in a month. Just let them titrate, let them go to 2000 or at least 1700 on the glucophage XR, and then visit them. A lot of time what I see happen is the patient start low dose, and then you try to see how patient responds and you take it there. What you want to do in the newly diagnosed diabetes is be aggressive, go directly, go the full speed, and see the response of the patient. And yes, if he's 8% and he becomes 6% is not a big deal. It's actually good. The lower, the better. So you can keep him and you don't have a concern about the hypoglycemia. And of course, there is no much added benefit if you go to 2500 from an A1C reduction. So, you can max it up about 2000 milligram a day. Now, the other part beside the glucose lowering effect, of course, do we have any data on the heart? Now, why is that important? Because patients, again, with diabetes have increased risk of cardiovascular disease. There's a shortened life expectancy. So typically, type 2 diabetes may have 6 years of life expectancy. That's shorter. But again, that really depends how well controlled, how many years of diabetes. Of course, somebody who gets diabetes at 70, they're not going to get 6 years of, years of loss versus somebody who gets diabetes at 30 and they have a BMI of 40. That's a whole different population. But also, if a patient have diabetic and early renal disease, they have 9 years loss. And if they have established cardiovascular disease, MI, stroke, with type 2 diabetes, they have 11 years loss. So the question, do we have any data to show any potential benefit on the glucophage? Now, when you treat patient with diabetes, again, based on the ADA guideline, if patient is established disease or very high risk, you need to start also with medication reduce the risk, such as GLP-1 and SGLT2. But the first thing is to try to categorize the patient. So if a patient, if you look on the right side, if a patient have type 2 with established disease, or they have target organ damage like microalbumin of 400, GFR of 30, they have very high risk category, and those patients will be treated directly and start with a treatment that reduce the risk. Now, again, it doesn't mean you cannot use metformin, but you need to make sure that the treatment include medication that reduce the risk even with metformin, that you don't only use metformin. Now, if a patient have type 2 diabetes without established cardiovascular disease, so primary prevention, if you want to call it, or any target organ damage, then you go based on their age. So if they're less than 50 years old and they have a duration less than 10 years, typically they're low risk, unless if they have 2 or more risk factors, then they're moderate risk. And really, they don't become high risk at age less than 50 unless they have 2 or more risk factors. And then when you look at population age 50 or more, again, 2 or more risk factors will have high risk. And then if they are having duration of diabetes over 10 years, they become very high risk. So again, when even you look at the ADA guidelines, it shows very clearly that those who are established as high risk or very high risk is different from different trials. But typically, they're over 55. And typically, they have 2 or more risk factors. And they say that very clearly in the ADA algorithm that I showed you earlier. So we'll go back to the UKBDS. Again, it's a very old trial. We don't have a same design as the new trials we have with the CVOT trials that was mandated after the Avandia data. But what the UKPDS included patients who were newly diagnosed, 4,200 patients, and mainly they were treated based on if they are overweight and non-overweight. So non-overweight, they either went to a diet, 727 patients, intensive treatment with sulfonylurea or insulin, about 1,800 patients, and then the overweight population went to either diet or intensive treatment with metformin, or intensive treatment with sulfonylurea or insulin. And then the overweight or non-overweight, they're taking SU and insulin uncontrolled, they will re-randomize to only continue SU or add metformin. What you see in this data, and you look at the Kaplan-Meier plots, and again, this is the metformin diet part, you can see that the diabetes-related death has been much lower in the group who are taking metformin versus the typical intensive group versus the conventional. There was significant reduction in the diabetes-related death, and not only that, there was a 39% reduction in myocardial infarction when you compare the two arms. The nice thing about the UKPDS is we have 42-year follow-up. Now again, a lot of patients died during those 42 years, but the benefit seems to continue on the trials after 42 years. We don't have any other anti-diabetic agent that we actually have 42-year data to look at the event, except this one. And what you see here, there was a reduction in the death from any cause, reduction in the diabetes-related mortality, and reduction in the myocardial infarction. And so it seems that the early intensive control, when you do it, especially with metformin, you are going to get a significant reduction in the event that seems to be lifelong, or here, 42 years. Now, this is a plot or different studies or meta-analysis looking at different trials looking at metformin, but you can see that the majority of the trial on the left side, so it shows that there is a potential benefit from the cardiovascular death across board. Of course, you have outlier that, such as the first one, which is the odds ratio was 0.11, but all of them on the left side, you don't have any of them that shows any data of any potential increased risk. So what it looks here very clearly that if you analyze the metformin trials, you can show very clearly that there is a significant reduction in all those trials, which included more than 1 million patients. And on top of that, if you look at this study, that's smaller trial, 372 patients who were admitted with HFpEF, so with a preserved ejection fraction between 2013 and 17. They did a retrospective analysis, and they look at the patient who were on metformin, non-metformin, and again, they showed that metformin users showed lower mortality or all-cause mortality by 51%. Now, is this an interventional trial? No, but it seems in all the trials, if you take it in all these trials, I showed you over 1 million patients, or if you look at this trial and go retrospectively, patients who take metformin seems to do better. Now, do we have typical study that the regular CVOT trials? No, because this started, only 16 years ago or 18 years ago. It hasn't been since the time of the glucophage. So we don't have such data, but we have the UKPDS I showed you. We have those data that confer more comfort regarding the potential benefit on the cardiovascular disease. The other part is really, this is the only drug besides insulin that you actually can use in the treatment in pregnancy. Now, of course, the drug is being widely used in either gestational diabetes, diabetes with pregnancy, polycystic ovarian disease. And again, you can use it as adjunct or alternative to insulin. And of course, even in the group who start metformin and have uncontrolled and need insulin, the group who take metformin typically will have benefit. And the benefit will be typically less weight gain if you compare to insulin only. So if you try to compare, typically, of course, on metformin, you're going to have less hypoglycemia. You're going to have less weight gain. And if you have it even in combination with metformin, you have less weight gain. There is a reduction in labor inductions. There is a reduction in cesarean deliveries. There's a benefit across the board, but we don't have the time to present all the data. And that's one of the reasons it has been approved to be used in the treatment or management of hyperglycemia in pregnancy. Now, the new formulation with the extended release has the ability to have delay absorption and maintain the systemic exposure. And that's really to negate the GI side effect, because really there's two side effects. Number one is the GI side effect, and number two, the potential low B12 in some patients. And of course, if patient have a high metformin index, so they're taking, 1,700, 2,000 for years, you may want to check their B12 maybe once a year, and measure their level. But beside that, the GI side effect is quite a bit negated, and I'll show you the data when you use the extended release. And here it shows you the graph between the exposure and the absorption versus the immediate release. So when you look at the side effect potential, you can see that the adherence is 96.5%. There's 77% less diarrhea. There's 53% less GI side effect. Now, typically, how do you dose it? Well, you have different formulation for the XR. So you have the 500, 750, and 1000. And what you do, you need to treat patient accordingly. What I'm trying to say, if you have a patient with diabetes, again, when you look at the diabetes prevention program, what was the treatment there? 850 milligram twice daily. So either use 850 twice daily glucophage or use XR 752 daily. For diabetes, you try to go to even 2000. I showed you the data from the 1997, showed very clearly there's a progressive A1C reduction all the way to 2000. So it does not make sense to consider drug failure if you did not use the drug correctly. So the glucophage is a little bit different than other drugs. So there are some drugs, for example, if you look at statin, and I use, let's say, rosuvastatin 10 milligram, from 10 to 20, you get only 6% more LDL reduction. But here, the difference is bigger. So you have to treat correctly and use the preferable or the studied dose. Now, the standard metformin, you can do the 500 milligram twice daily. You can push it 3 times daily. You can do the 850 milligram twice daily or the 1000 twice daily. The XR, preferably you take it at dinner. Again, that's the recommended intake. And you can take either 1 in the evening or 2 of the 750 in the evening or 2 of the 1000 in the evening. Of course, you start 1 tablet and then you titrate the title. So at the end, I hope I just reviewed some data that's very old. I'm not saying anything new. But we have to remember that diabetes is a continuous disease. It starts way before and with the prediabetes. We have a treatment that helps in prediabetes. And when you look at the glucophage in the diabetes prevention program, it is as effective as life intervention, especially in those with BMI 35 or above. And I showed you the data follow-up 15 years, showing clearly that patient maintained the reduction in the progression of diabetes and maintain the weight versus the lifestyle intervention, they regain their weight. And it's the only drug approved really for diabetes prevention. The optimal dose, again, for prevention has to be as the study. So 1500 milligram of the XR, or I would do 852 daily as the diabetes prevention program. It is really the only drug beside insulin that you can use in pregnancy. So that's an added benefit. So it's part of the continuum. You can take it before you're diabetic. You can take it early in the diabetes. You can take it even when you're pregnant for female. And you can keep it with insulin because that will help reduce the insulin intake and the insulin dose. And that's important because you reduce the further weight gain. So when a patient go to insulin, and if you need to go to multiple dose insulin, typically you will stop the sulfonylurea, but you don't stop the glucophage. The XR formulation will improve the adherence, will reduce the side effects. And again, it's very inexpensive drug compared to the new treatment, and we have to keep it one of the treatment available to start early in the diabetes. Thank you very much.
Thank you so much, Dr. Jalal.
Thank you.
Great lecture. Thank you so much. We have time just for a short question. Does metformin still have cardiovascular benefits?
Well, I mean, the short answer, if you're going to use CVOT trials, the answer is you cannot prove it one way or another. As far as I know, they're running an actually CVOT trial, but as I remember, it's pre-diabetes, not in diabetic per se. But I mean, again, pre-diabetic already have a higher risk. So we'll see how the result looks like. But I mean, what I showed is mainly the UKPDS, which is mainly to answer 2 answers. Number 1, does early intervention works? and it seems it works because in this group that went, again, the UKPDS, not everybody in the conventional quote-unquote diet stay on diet. By the end of the 10 years, the majority were not on a diet. So they progressed over years. So like in 3 years, I think 40% already went on medication and so on. But when they intervened early, it seems to work better in a perspective of cardiovascular benefits. But again, as I mentioned, we don't have a typical CVOT trial. So, you take the data as the way it is, and you can make your own conclusion. And even when you compare it to the SU, there was a benefit. So it seems to be more reduction. So if you're aggressive in a glucose lowering effect, it seems to be better in SU than diet, but it's even double the benefit in a way if you do the glucofunction. And then the other data, I showed meta-analysis, and the other one on the HFpEF, there's data actually on arrhythmia. So there seems to be an effect even as anti-arrhythmic. So this is what we have really.
There's another important question that I will take, is that what should be the starting dose of metformin for pre-diabetics and diabetics? So again, there's a lot of talk about this. So I think it's important to clarify that.
So, and that's why you've seen in the talk, actually, I mentioned it multiple times. So pre-diabetes, I'll use 850. I'll do it maybe for a week, then I'll go 850 BID. So if I'm going to do a drug based on a trial, I do exactly what they did in the trial. I have no
So
proof.
in other words, you're not doing, because we see a lot of patients who are on 500 daily, 1,000 daily. Yeah.
Again, it's not because I'm speaking to Merck, by the way, to improve prescription, but the study was done a certain way. I have to follow the study. I cannot make projection. You know what I mean? So I will do it this way. So like, for example, I'll give you a different idea. If you talk, let's say, in AGLT2, let's say IMPA, and I know I'm not talking about it, but when they did the analysis in the IMPA, they had 10, they have 25, and they showed the same benefit. So if you're talking cardiovascular benefit, for example, in IMPA, it's the same for 10, 25. So it doesn't seem there's more benefit if I go from 10 to 25. Glucophage, if we're talking pre-diabetes per se, then it has to be done this way. So I will do it this way as diabetes prevention. Diabetes, I will go right away aggressive. Even if the A1C 7.1, I'll go directly to 2,000. And even if the A1C dropped to 5.9, actually, there's more data that actually, if you keep it very tightly controlled, i.e. preferably below 6, and again, there is no risk of hypoglycemia, you're more likely to be able to preserve the beta cell function. There was in the prior talk about the VERIFY trial, and again, VERIFY was metformin GABAs, but the concept is the same. They started treatment at 6.8%, so they went very aggressive right away, and that seems to work. So, that's what I would do.
Thank you so much, Dr. Jalal. Very informative as usual. Thank you so much.
Thank you.
And now we can go on to our next talk. Our next talk is by Dr. Hussam Zaki, who is a consultant cardiologist at Dubai Hospital at Dubai Health in the UAE. He will be talking about exploring the bidirectional link of shingles in patients with underlying cardiovascular disease. Dr. Hussam, over to you. Dr. Hussam, we cannot hear you, I think.
The burden of herpes zoster in patients with cardiovascular disease. Why it is important to protect your patients from shingles now? Well, 99.5% of adults above 50 years old are infected with varicella zoster. Herpes zoster is caused by reactivation of varicella zoster in adults. So it starts by chickenpox. Usually the infection occurs in childhood and manifests as generalized vesicular rash. Latency, a period of latency, varicella zoster established latency, and the primary infection induces cell-mediated immunity, preventing subsequent infection and reactivation. Then the point is reactivation can happen later in life when immunity drops and causing a distinctive dermatomal rash and pain. Herpes zoster symptoms and disease course. The natural course of herpes zoster consists of prodromal, and acute phase, which can be followed by the chronic complications. A prodromal phase of 4 days to 2 weeks where there is headache, photophobia, malaise, abnormal skin sensation, pain, fever. Then the acute phase, when the patient develops a unilateral vesicular rash associated with acute pain. Sometimes there is a subacute phase where the lesion crosses over and resolves. And 5 to 30% of the patient develops post-herpetic neuralgia, the most common complication. And this post-herpetic neuralgia is defined as a neuropathic pain that persists for more than 90 days after the onset of herpes zoster rash. And we can see scarring, pigmentation persisting long after the lesion have healed. 10% of patients with severe herpes zoster have scarring of up to 6 months. Patients may suffer clinically significant pain that could be long-standing. When they did the zoster brief pain inventory score, the classified patient, 87% would have a clinically significant pain, 62% would have a severe pain, and 17% will have the worst imaginable pain. According to the score, this is less than 3, this is between up to 7, and this is more than 10. So the pain or the post-herpetic neuralgia is very significant. How this affects the patient's life in a qualitative cross-sectional study in patients affected with shingles above age of 50, 97% described as decreased activity of daily living. 91% described affecting sleep. 78% had the effect on the physical functioning. 97% has the effect in emotional functioning. 63% affected their social functioning, and 28% affected their cognitive function. So it's not simple. Shingles is associated with a spectrum of complications. Of course, they are not all common, but ocular, like herpes zoster ophthalmicus, can have ocular involvement and cause vision loss. Common ocular complication can include keratitis, uveitis, iritis, and conjunctivitis. Post-herpetic neuralgia is the most common complication, is a neuropathic pain that can remain after the shingles rash heals. It can last for months and occasionally persist for years. Neurologically, although rare, shingles is associated with neurological complications as Ramsay-Hunt syndrome and meningoencephalitis. Ramsay-Hunt syndrome is affection of the facial nerve with peri-ear vesicular eruption and peri-ear pain. Vascular complication, rare. Shingles can be associated with vascular complications such as a stroke and myocardial infarction, and this will detail in our talk. Also, cutaneous complication, while uncommon cutaneous complication associated with shingles includes secondary bacterial, skin infection, scarring, and pigmentation. So who is at risk of shingles? Age-related decline in immunity is the dominant driver of shingles. So above the age of 50, cell-mediated immunity starts to drop. And if you see the natural history of the disease, the patient gets the primary varicella zoster infection induces chickenpox. Then varicella zoster specific cellular immunity may be boosted periodically via varicella zoster exposure or silent reactivation from latency. Shingles threshold here starts to drop, but by the age of 50 and above, varicella zoster specific cellular immunity declines with age, and the decline in cellular mediated immunity is associated with increased risk of shingles. So age is a major driver for the reactivation, and we can see this also from the sharp increase in number of cases above the age of 50, and consequently the sharp decrease in cell-mediated immunity between the age of 40 and 50 is like 2 times, 50% increase. Also, post-herpetic neuralgia incidence increase with age. The more the patient ages, the more it increases. There is usually a viral disease and chronic condition. There is a bidirectional relationship between the viral disease and complications associated with chronic condition. We can see that viral disease can lead to complications, and complications and chronic conditions can lead to susceptibility, being the patient friable and weak to the viral. What would this lead to? Inflammatory cytokines, hypercoagulable state, plaque destabilization. All these can lead to vascular complication, whether in the brain or in the heart. Common comorbidities that can increase the risk of shingles. It's diabetes, COPD, asthma, chronic kidney disease, cardiovascular conditions, patients in heart failure, patients have extensive ischemia, and also being on immunosuppressive therapy. Those treatment like oral corticosteroids or immunosuppressive therapy are associated with increased risk of shingles. Our case study, shingles in a patient with a coronary artery disease. He is a 52 years old male, overweight, BMI of 30, heavy smoker, family history, strong for coronary artery disease at a younger age, hypertension, ischemia, and currently on candesartan and atorvastatin. Initial presentation, severe eruptive pruritic rash on the right side of the abdomen, suggestive of shingles infection. Non-steroidal and tramadol for the control of pain, acyclovir 900 milligram on 3 doses should start within the first 72 hours. In the follow-up, rash resolved completely after 4 weeks. Patient reported persistent pain at the site of shingles rash, confirmed post-herpetic neuralgia. Treatment can be up to gabapentin, and usually only 17% of patients will be satisfied with the pain control. Post-herpetic neuralgia resolved after 3 months. So this patient suffered for 3 months. What is the risk of stroke or MI following a herpes zoster? Potential mechanism by which herpes zoster disease may increase the risk of cardiovascular events. Varicella zoster reactivation in sensory autonomic ganglia leads to systemic inflammation. We can monitor it by a rise in CRP, inflammatory cytokines like interleukin-6 and interleukin-1b. Also, autonomic dysfunction with sympathetic tone increase and blood pressure increase, and this can alter immunologic status. Also, varicella zoster vasculitis, virus may travel to and infect cells within cerebral or coronary arteries. This to influx of inflammatory cells, release of enzymes and oxygen peroxides, vascular remodeling, thickening of the vessel inner layer, narrowing, occlusion of lumen, weakening of arterial wall. On the other side, inflammatory cytokines leads to increased thrombosis. All these together will lead to vasculopathy, and vasculopathy can lead to a stroke or MI. So, another case of a stroke. It's a stroke in a patient with shingles history. Background, a 66-year-old male, heart failure with preserved ejection fraction. NT-proBNP is 1800 picogram per ml. Type 2 diabetes, hemoglobin A1C of 8%, diagnosed with herpes zoster ophthalmicus 3 months ago and treated with antivirus. The current medication are dapagliflozin, semaglutide, furosemide. The patient reported 10 days of generalized weakness, fall, and forgetfulness. MRI brain scan revealed acute ischemic stroke in left frontal lobe and centrum semi-ovale. Varicella zoster vasculopathy diagnosed based on clinical presentation supported by positive varicella zoster antibody test in the cerebrospinal fluid.
5 minutes left.
Yeah. Patient was treated with IV acyclovir and high-dose prednisolone in hospital. Once clinically stable, patient fitted with central cannula and discharged with 2 weeks acyclovir IV. So this is how it could be. So although rare shingles may be associated with vascular complications, the stroke risk or increased relative risk by 34% in a study of a stroke in a US study. Stroke happened in 0.73% of adults with shingles versus 0.4 in those controls, so more strokes. Also, in that summary, there is like 16 study reviews, meta-analysis, all supported that shingles increase stroke. Also, by age, it happens more on those younger age. What about the risk of infarction, myocardial infarction? It increased by 35%. A study in the US, they found that it is 0.53% in adults, increasing MI versus 0.2 in controls, and it is more in elderly. So MI more in elderly, stroke more in younger ones. Also, how can you protect your patient against shingles? And this I will finish with. Treatment options for shingles and its complications are limited and suboptimal. Antiviral treatment of acute shingles within 72 hours of the rash. You should not wait. Antiviral can reduce shingles severity and duration. Oral acyclovir does not reduce post-herpetic neuralgia. Insufficient evidence for other antivirals. Rash lasts for 7 to 10 days. Management of shingles pain starts at the acute phase and can last years. Patients with post-herpetic neuralgia commonly need multiple pain-controlling drugs that are often ineffective. Analgesics, anti-inflammatory agents for acute shingles, drugs for neuropathic pains, and only 14% of patients of post-herpetic neuralgia are satisfied with the treatment. We can see that shingles should be given, it is combined recombinant antigen and adjuvant system to stimulate the immune system. When you have an adjuvant in the formula rather than the old one, it stimulates the cellular-mediated immunity more, and it is given in 2 doses, the first one at 0 point and the second after 2 months. At this point, I will just stop because of the time, and I will be happy to address your questions.
Thank you so much, Dr. Hussam. Rich and important lecture as usual, as per all your lectures. Thank you so much. So it's very interesting that I can see now more and more subspecialists like yourself are raising awareness about shingles, and not only neurologists and primary care physicians as we were used to. How much do you think is the awareness amongst subspecialist physicians also important in raising the disease and vaccine awareness?
In the field of cardiology, talking about vaccine is something like you are talking about something very far. Although those patients with heart failure, they are immunocompromised, we always vaccinate them with pneumococcal vaccine. We always vaccinate them with influenza or flu vaccine. But I think now with this a vaccine which is not live attenuated, so it will not affect the immunocompromised. On the contrary, it will benefit. This vaccine will be very helpful in improving the outcome and decreasing the complication of cardiac patients. It's very important.
Thank you. So there's an other important question. So one of the doctors is asking, should shingles history influence your cardiovascular assessment of the patient?
Yes, you should be aware because it could be the trigger for a stroke. It could be the trigger for an MI. Of course, you have to treat the MI the conventional way, but if there is a history of shingles, then you should put in mind that even vaccinating somebody who had acute shingles after stabilization after like 1 year is also very helpful to prevent further recurrences.
Are younger patients at risk of shingles also?
Yes, it's not the shingles. It's those around 40 years of age. They are more vulnerable for a stroke. If you see the data we presented, elderly are more prone for MI. Younger are more prone for stroke. But of course, the most common is the post-herpetic neuralgia, which in so many studies have seen that it's affecting the quality of life very much.
All right, one final question, Dr. Hussam. Can Shingrix still be given to high-risk diabetics who have already had chickenpox?
Yes. Having chickenpox, this is for granted because 99.5% of everybody had it. The issue is you give it to them, but if he has a recent shingle, then you have to wait a little bit till he stabilizes, maybe 6 months or 1 year after the recent infection, then you immunize, because when you raise the cellular immunity, you will decrease the incidence of recurrence and incidence of other complications.
Dr. Hussam, thank you so much. Thank you so much for all this info, and hope to see you soon, inshallah.
Thank you. Thank you.
So now after this wonderful lecture by Dr. Hussam, we go on to our next talk by Dr. L.N. Rao. Dr. Rao is a consultant endocrinologist at the Imperial College London Diabetes Center in Abu Dhabi. He will be talking to us from theory to practice transforming metabolic health with Mounjaro and Fondeo. Over to you, Dr. Ram.
Thank you so much for a very kind introduction. Good afternoon, ladies and gentlemen. We had lovely discussions about a variety of topics, and now we're going to get into the meat of the obesity and the metabolic health and how we can bring the best practice to our patients. And thanks to Lily for providing this platform and opportunity to discuss this very important topic. That's the information that we all need to know in terms of today's discussion is mainly devoted information related to the Foundayo and Mounjaro and its indications, going through some cases. Any questions unrelated can be directed to medical department. These are my disclosures. So these are the two drugs I'm going to discuss this afternoon in the next half an hour or so. We know Foundayo, the oral orforglipron tablet, the one and only non-peptide GLP-1 analog, has been FDA approved a couple of months ago, and we will see how it can fit into our management armory to help our patients to fight overweight and obesity. Its indications, obviously the licensing is mainly for overweight with BMI 27 or above with at least one weight-related comorbidity or obesity in adults. And when it comes to Mounjaro, I just want to make it clear in the first slide itself as to the licensing indications. It was licensed for type 2 diabetes around 3.5 years ago, 4 years ago approximately, initially in adults, but recently this has been expanded to children aged 10 and above as well, circa December 25. Whereas when it comes to weight management indications, the same injection obviously is only licensed for adults with overweight and weight-related comorbid condition or obesity. With that licensing information, I will take you through the journey of 3 patients, showing you the variety of stages of the obesity and its metabolic conditions associated with, applying the evidence from ATTAIN-1, SURMOUNT, and SURPASS data so that we can decide the management for our patients with confidence. What is obesity? We have struggled as clinicians dealing with persons living with obesity in terms of getting them management options to start with, getting them
Dr.
funded.
Rao, sorry for the interruption. We can't see your camera actually.
You can't?
Can you switch it on?
Yeah, it is on.
Sorry for the interruption, everybody.
Fahad, it is on. Can you hear me?
Yes, we can hear you, doctor. Yes. Can you just switch it off and on again? Can you see yourself? If you see yourself, then it should be okay.
It's fine, Dr. Fahad. If it's fine. I think at the Q&A. So we don't disrupt Dr.
Sure. I'm sorry for the disruption. I'm sorry. You can go on, doctor.
I can't see the slides now. Oh, they're back now. Okay. I was able to see myself, but now it's gone actually. Anyway, can you able to hear me? Hello?
Yes, we can hear you.
We can hear you perfectly. You can go ahead, yeah.
Okay. So what is obesity? Obviously, it's defined as a chronic, progressive, relapsing, and multifactorial disease influenced by a variety of factors in terms of genetic, psychosocial, environmental, physiological. Obviously, we tend to hear this from patients that, doc, I'm not eating much at all. I'm trying my best in terms of exercise, but still I'm not able to lose weight. This is a common connotation we tend to hear in the clinics. And, obviously this is proven by the nature of the disease itself, where not everybody will have the calorie deficit in the same way or calorie expenditure in the same way. It is dependent upon several factors, like I've just alluded to. Accordingly, thankfully, majority of the societies across the world have acknowledged obesity as a chronic condition, making it ever so slightly easier for patients and clinicians treating with it in terms of managing these patients. This is an important cartoon I really want you to focus on, because obesity acts as the gateway to this cardiorenal metabolic syndrome. This concept of CRM syndrome has been into the limelight in the last 3-4 years, initially addressed by American Heart Association, as you can see from the footnote here. So what is it exactly? So stage 0, if a person with no risk factors, normal weight, no other metabolic conditions. Stage 1, where you tend to develop overweight or obesity with dysfunctional white adipose tissue mainly, and they might have hint of metabolic problems like obesity-related problems like visceral adiposity, increased waist circumference, possibly IFG, IGT. And then when it progresses to established metabolic risk, like metabolic syndrome factors like hypertension, type 2 diabetes, etc., you call it stage 2. And then that progresses to subclinical ASCVD, which is stage 3, and clinical CVD, which is stage 4. So if we can catch our patient early and address their risk factors appropriately, mainly the obesity, which, as I say, is the gateway for the CKM syndrome, we can prevent the progress of a person from stage 1 to the stage 4 and improve their morbidity and mortality. So that is the whole point of this talk today, really, with some examples. And we have evidence. We have abundant of evidence in terms of what happens when we treat obesity, what it can do to the metabolic mayhem that can happen in these persons with obesity. We can reverse these metabolic conditions depending upon how much weight loss we can achieve and sustain. That is the important one, sustain as well. So there are a lot of diet and lifestyle things that are out there, which are important, but unfortunately, no single extreme diet is sustainable. And that is why we tend to see quite often in our clinics where a patient tried a particular diet for 2 months, 3 months, lost some weight, but unfortunately put it back on. These are very common examples that we tend to see. So if we can lose this kind of weight and sustain it, we can reverse these pathologies as I have put in there, including type 2 diabetes remission. That is possible. We have seen it in studies after studies. We can reduce the CV disease and CV mortality if we can sustain after losing around 15% of weight. MASLD, PCOS, in fact, sleep apnea, all these things are proven to be reversible if we can achieve meaningful weight loss. So I'm going to take you through some patients here, starting with Mariam. Meet Miss Mariam, who is a 40-year-old lady with BMI just around reaching the 30, just getting into the obesity range, with borderline stage 1 hypertension, atherogenic dyslipidemia, as you can see, high LDL, lowish HDL, high trigs, typical in people with obesity. And she has come to you saying that she has tried all kinds of diet and physical activity measures, but unfortunately could not sustain the weight loss she has achieved. She has 4 children, busy life, works full-time, so she's struggling. If you look back into her notes over the last few years, clearly she has progressed from weight of 78 to the current of 84. And obviously you can project this putting on the graphs, and obviously she's going to get worse in terms of her weight and waist circumference if we don't do anything today. So that is why the patient is here. That is why she is seeking medical opinion. Now we have the Foundayo, the one and only oral non-peptide GLP-1, which is a very simple administration without requiring any food and water restraining requirements as such that we tend to have with other oral GLP-1 in the past, which were used for type 2 diabetes. This is a very small molecule, very clear non-peptide. The word non-peptide is important because peptides, as you know, when you administer orally, they can be destroyed by the gastric juices. So very cleverly, they have designed a non-peptide molecule as an oral molecule with GLP-1 agonist actions. When you look at the ATTAIN-1 study, which is the study looking at the people with overweight with comorbidities or obesity, taking orforglipron, the Foundayo, over the 72 weeks, you can clearly see with variety of doses of Foundayo, there was around 8 to 12.5% of weight loss, which is compared to just 0.9% with the placebo. And this is very important, like I've shown you in the previous slides, what 5% or what 10% or 13% weight loss means. That means you're reversing the metabolic risk factors that could be already set in a particular person. Like in our patient, she has stage 1 hypertension, she has raised TG, so this is meaningful. And not just the weight loss, we are looking at the health gains here. Obviously weight loss is one thing, and obviously providing their metabolic health back in the track is another thing. And that is where Foundayo in this ATTAIN-1 study, you can see systolic blood pressure was reduced by around 7 millimeters of mercury over 72 weeks. Improvement in lipid markers, as you can see here, improvement in waist circumference by around 11 centimeters, which is extremely important because waist circumference is indirectly an indicator for visceral adiposity, which is very closely linked to metabolic risk factors. Not only that, the hsCRP, the chronic inflammatory marker in the body, is also reduced by around 50% with the found patients compared to placebo. That again showing reduction in the chronic inflammatory milieu, which again is important in preventing vascular endothelial damage. So what about adverse risk factors? So whenever we have a new drug, as clinicians and patients, we are worried in terms of what other side effects it can cause. So this is a GLP-1 agonist molecule. We have seen GLP-1 molecules for almost 10, 15 years now. So similar kind of side effect profile in terms of GI side effects, especially when you start the medicine and with each escalation, which goes away after a few weeks once patients get used to it. So namely nausea, diarrhea, constipation, vomiting, these are the common side effects as you can see from here. Not necessarily dose dependent, as you can see here, some of them are higher with 9 mg, some of them are higher with 5.5, and some of them are higher with 17. But these are the things that we need to educate our patients with. Slide continues with other GI disturbances, adverse reactions that you see here. Mostly mild to moderate GI disturbance and CVRD, as you can see here. It comes in a variety of doses, 6 doses, namely, as you can see here, starting with 0.8. Each dose escalation, before that, we need to wait at least 1 month before we escalate the dose, and that applies to each of the dose escalations, going up to 17.2 milligram, which is the maximum dose. Thankfully, the doses are marked with G1 to G6, as you can see on the tablets, and the tablet colors and the shapes are different as well, so that there is no confusion for the clinicians as well as for the patients as well, which I thought was quite helpful. Now, why does Foundayo fit for our first patient, Miss Mariam? She is at the early stages. She just, transitioned from like overweight to obesity. She has got very early kind of borderline hypertension, a little bit of dyslipidemia. She's tried diet and lifestyle. Of course, we need to remember any pharmacotherapy that we use in our patients should be accompanied by ongoing diet and lifestyle changes, fitting to or tailoring to patients' requirements and necessity. So it's at most important to remember that diet and lifestyle continues to be part of the management even when we're using pharmacotherapy. The key thing with this tablet for me is there is no food or water restrictions which can fit busy individuals like our person, Ms. Mariam here. And obviously her hypertension, which was 134 systolic, if I remember right, we could expect that to revert into normality if she is able to use the medication and attain that meaningful weight loss of at least 5 to 10%, which is quite possible given the data that we have seen, a maximum of around 12.5% weight loss. So moving on to second patient, Miss Sarah. So Miss Sarah is different slightly from the first person because her BMI is on the higher side, waist circumference is on the higher side. She's edging towards the pre-diabetes. She's got, again, atherogenic dyslipidemia, importantly, very high triglycerides, and obviously stage 1 hypertension. So she's a little bit more advanced in that CKM syndrome. If you remember the cartoon I've shown you, maybe stage 2, I would say. So again, this is where the twincretin fit, the one and only dual agonist that the Mounjaro is, GLP-1 and GIP agonist, synergistic mechanism with this dual agonist mechanism. Obviously, they work at different sites. The Mounjaro decreases the appetite at the hypothalamic level so that you don't feel hungry and your satiety levels are increased. And at the same time, there is a reduction in the gastric motility in the stomach level, obviously feeling full with small amounts. That's what people say most of the times. And especially if they try to eat more like before, then they can feel these side effects, nausea and other side effects. So again, patient education is important. Listen to your body. Try to avoid oily, bulky, fatty kind of meals. Small portions. You can have multiple but small portions. And the GIP is very interesting because this has action at the human adipocytes, resulting in a positive way of lipid uptake and lipolysis that can add to the benefit of this particular drug, increasing the weight loss that we tend to see with the dual agonist compared to pure GLP-1 agonists, increasing the insulin response to the meal, again, improving glycemic levels in type 2 patients. So this is different from the pure GLP-1 agonist, where we have enhanced action coupled synergistic agonistic action with GLP-1 and GIP agonists. So SURMOUNT-1 is the important study with this particular context, obesity, using of tirzepatide in adults to treat obesity. Obviously, at 72 weeks, with doses 5, 10, and 15 with blue, pink, and red, as you can see from here. People with obesity lost around 16 to 23% weight reduction. This is unheard of before in the medical arena. Except for in the context of bariatric surgery, we did not have this kind of weight loss with any pharmacotherapy, medical pharmacotherapy in patients, in persons living with obesity. This is phenomenal compared to any other drug that we had before, 22.5% weight reduction on average in adults with obesity over 72 weeks with Mounjaro 15 mg. Now, you can imagine what that means to patients, you know, reversal of almost every single metabolic complication that you can think of if we catch them early and treat them appropriately. Now, this doubt arises in patients and clinicians' mind. What happens after 1 year? Is this sustainable? Is the weight loss is still maintained after, say, 2 years or 3 years? And that is what this particular 3-year prolongation of SURMOUNT-1 answers. Clearly, as you can see, the 5 mg, 10 mg, 15 mg continues to provide the same benefits for those patients who are able to use the drug beyond 1, 2, 3 years. And you can clearly see at the end of the study with the 15 mg, we are looking at phenomenal, almost 23% weight loss, which is great for our patients. Not only weight loss, again, I keep talking about health gains. And these are the health gains that these people attained in this particular study in SURMOUNT-5. You can clearly see 10 mils of mercury reduction of systolic blood pressure on average in these patients. Compare that to the injectable semaglutide, it's around 7 mils. Diastolic around 4.5. HDL cholesterol improvement, LDL decrement, phenomenal reduction in the triglycerides. This is almost around 0.5 millimole per liter, which is around 35 milligram per deciliter. So every single parameter you can see here compared to semaglutide is much higher, much better for our patients in a positive way. So dosing is, I'm sure most of you are aware of, start with 2.5 milligram per week dose. After at least 4 weeks, we can escalate the dose to 5, and then after that individualize as needed up to 15 with each 2.5 milligram per week escalation. We need to wait at least 1 month prior to escalating dose. With each dose escalation, please remember to educate the patient. The side effects, the GI side effects mainly, can be slightly higher, the nausea and sickness. And obviously, again, patient education is the key. So why does this particular injectable tirzepatide, that is Mounjaro, fits with our second patient? Because she's tried several things already. She tried, failed. She's a bit vexed up. She wants something robust but sustainable as well, and also addressing her other metabolic and physiological and physical complications that she already have, like mechanical back pain, blood pressure, triglycerides, etc., etc. So this is the reason why this particular drug can fit into her. So imagine even if she were to go up to 10 milligram dose, she can achieve 20-21% weight loss, which brings her into a very comfortably safer zone. Take this a notch higher and discuss about this patient with type 2 diabetes. So as I've shown you in the earlier cartoons, obesity can be considered as often entry point to this the CKM spectrum as such. So what if somebody already developed, say, sleep apnea or type 2 diabetes? What about that? Again, we have evidence in that context as well. Let's look at that. This is important because people with obesity are at least 5 to 10 times at higher risk of developing type 2 diabetes. They're also very swiftly progress to diabetes within 5 to 10 years. So meet Miss Nadia, recently diagnosed with type 2 diabetes. She has been struggling with obesity for many, many years. Our A1C currently is 7.4%. We need to remember achieving A1C targets is proving more and more difficult for people with obesity, and this is data here. As they progress from normal BMI to morbid obesity, the chances of them failing to achieve A1C less than 7% increases exponentially. As you can see, more than half the patients with the class 2, class 3 obesity are unable to reach their glycemic targets in spite of multiple medications. And we know glycemic control per se on its own, even without considering other metabolic mayhem that happens in these persons living with obesity, is enough to cause vascular complications, both micro and macrovascular complications. That is why ADA and ESD clearly put a greater emphasis on weight management as well in people with type 2 diabetes, because that itself can address a lot of risk factors that they have. So coming back to our last patient, Ms. Nadia, who has type 2 diabetes, already having struggled with obesity for many, many years. So clearly, this is where the SURPASS-2 comes into the picture, where people with diabetes were tested with tirzepatide, the dual agonist, the GLP-1 and GIP agonist, and looked at the A1C reduction, as you can see here, compared to semaglutide 1 mg in the gray color here. So 1.9 is with the semaglutide. Compare that to even the 5 milligrams of Mounjaro, which attained 2.1 superior A1C reductions compared to the semaglutide. And that goes up to 2.5% with the higher doses A1C reduction. That is unheard of, unless with insulin. There's no other drug that can do these kind of reductions to the A1C as such. Not only that, the weight change is also seen. Obviously A1C reduction is one thing, and the weight reduction, you could think about what happens in these diabetes patients. There is still weight loss, again, much superior compared to semaglutide injection, going up to around 8 to 12.4 kilograms of weight reduction with the Mounjaro 5, 10, and 15. You might be thinking, why is there slightly lesser weight reduction compared to non-diabetic patients with the Mounjaro? There are a lot of reasons for that, because diabetes patients, as you know, they're a bit more advanced into this metabolic mayhem because of the chronic inflammation, insulin resistance. It's difficult for them to lose weight. And also, when they have poor glycemic control, they're losing a lot of glucose in the urine, calories are lost, so the weight loss is there. Whereas when you control their diabetes, obviously, the glycosuria goes down, the calorie loss goes down as well. So that is another reason why you may see lesser weight loss in people with diabetes compared to non-diabetic patients. And it is a different disease spectrum as such. Established type 2 diabetes in obese persons, they are a bit advanced into that chain of CKM syndrome I have shown you. Yeah. And there could be another medication like sulfonylureas or insulin or glitazone, which again prevent them to lose weight even when using Mounjaro. But still, there is a significantly meaningful weight loss. What about the composite endpoint of SURPOINT-2, which is a combination of achieving A1C less than 6.5%, achieving weight reduction more than 10% without having any hypoglycemia? So that was the composite endpoint. You can see Mounjaro outrightly beaten the semaglutide 1 mg, even with the 5 mg dose, 32% versus 22%. And you could get these composite endpoint in 60% of the persons using Mounjaro 15 mg. That is quite phenomenal, I think. Getting A1Cs less than 6.5%. More than half people were able to get A1C less than 6%, and into the normal range, around 1/3 of them in this study got A1Cs less than 5.7%, which is phenomenal. Again, what happened to their other metabolic risk factors? Reduction in the blood pressure, very nicely coming down, systolic and diastolic, 20 to 25% reduction in the triglycerides, and reduction in the waist circumference, which again indirectly link it to visceral adiposity. Side effects, clearly, as you can see, GI side effects like you see with any other medication in this class. Nothing dramatically different there between the drugs. And obviously, this is why I think Mounjaro fits in our third patient, because her A1C was uncontrolled. She was struggling with obesity, and she was also having other metabolic risk factors established. So to give her protection from cardiovascular, renal morbidity, and mortality, this feels like the optimum choice for her. So what to remember from this talk over the last 25-30 minutes? Obesity is not a choice. These people are not obese because they're just eating more and moving less. That is a myth. That perception has to change from clinician perspective, policymakers, and everybody else as well, which I am glad to say over the last 15 years has changed significantly. This is a very complex, relapsing disease and should be seen and treated in such a way so that our patients can get the right help in the right time, so that we can prevent the development of complications that I have shown you in that CKM spectrum as such. We have choices now. We have Foundayo, the oral GLP-1, non-peptide GLP-1, which fits nicely into, I would say, probably stage 1, stage 2 CKM, and even in patients who prefer oral medication, even when they're stage 3 and stage 4. We have Mounjaro, obviously this once weekly injectable tirzepatide, which fits very nicely into any stage of obesity syndrome with or without complication that I've shown you there. Every single therapy, please remember, should be coupled with diet and lifestyle as well. When people with type 2 diabetes present to you, you're going to treat them two targets by choosing the Mounjaro in terms of their obesity as well as their type 2 diabetes as well. We have mammoth of experience and evidence from the studies that I've just shown you, the ATTAIN-1, the SURMOUNT pathways and the SURPASS pathways we have both in diabetic and non-diabetic population. And in terms of side effects, it's mainly the GI side effects that are mostly mild to moderate, manageable with appropriate patient education and counseling that we can do in the clinics. So I think we've already discussed this, and I'm happy to take any questions. Thank you very much for your attentive listening.
Thank you, Dr. Rao. We have a lot of questions actually. Let's begin with, there's a patient with a history of breast cancer. Is it safe for them to use, in your opinion, GLP-1 agonists? And is there any data about increased risk of relapse in such cases? And finally, in this case, would you rather start Mounjaro or Foundayo?
Right. So to start with the first question, of the multiple question in this, the breast cancer is not a contraindication for use of any GLP-1 or GLP-1 GIP agonist as such. The only contraindication that you see in terms of cancers is if somebody has personal or family history of medullary thyroid cancer, which can be associated with MEN syndromes, purely because in the animal studies, the rodent studies, they have seen the hyperplasia of the C cells, which can be associated with this medullary thyroid cancer, which is an extremely rare form of thyroid cancer as such. So it is not a contraindication. You can use it, but which one to use obviously it depends upon the that particular patient's profile. Does she have type 2 diabetes, in which case only tirzepatide is licensed at the moment. Foundayo, as I have alluded to at the very beginning of my talk, is only currently licensed for people with overweight and obesity, not for the context of type 2 diabetes yet. There are studies going on. Obviously, as you know, there is a ACHIEVE program studying in diabetes patients, but at the moment, Foundayo does not have license to treat type 2 diabetes as such.
Thank
and
you
other
so
things
much.
to consider in that patient is where exactly is she in that CKM spectrum. If it is grade 2, grade 3 obesity with significantly established medical risk factors, and we're looking at maybe 15 to 20% of weight loss, then Mounjaro will become the obvious choice, compared to if we are looking at 10-15%, then the Foundayo will be another chance. And again, patient's preference, tablet versus injection.
How comfortable are you in starting GLP-1s for patients who have a history of other types of thyroid cancer other than medullary thyroid cancer? So are you comfortable with starting them, or would you be a bit cautious?
This is a very important question because, I tend to see a lot of patients having had scans for no reason, and because just we're going to start the medicine, that's why we had the scan. So there is no information or evidence to suggest that doing next scans before starting these medications is mandatory. There's nothing to say like that. Of course, if you have a clinical suspicion, if a person comes to me in the clinic and says, I have my sister or my brother has this, say for example, papillary thyroid cancer, I would obviously examine them, take the history, and if I suspect anything in the neck, I might go for the scan. But otherwise, again, it's not a contraindication, because there are at least 4 types of thyroid cancers, and the only thyroid cancer they talk about in rodents is the medullary thyroid cancer, not papillary, not follicular, not others, anaplastic.
Anaplastic, yeah. Okay, so again, people are very concerned about the contraindications. So another question is, how frequently do you see pancreatitis with Mounjaro or Foundayo?
So most of these drugs, if you look at the studies there, it's quoted around 0.1 to 0.3%. That's around 1 in 500 to 1 in 1,000 patients. So I would be cautious in patients with history of gallstones, unless it was attended to, because the people who had pancreatitis in these studies were the people who were at least already had risk factors to develop pancreatitis. That could be hypertriglyceridemia, that could be gallstone disease, that could be excess intake of alcohol, the usual common risk factors that we see for the pancreatitis, or family history of pancreatitis before. So again, patient history and education is quite important. Most of the time, these patients have had an ultrasound at some point of their journey, which could tell you about whether they have gallstones. If there is a big gallstone sitting in the neck of the gallbladder and they come to you for this injection, I would suggest them to get a surgical opinion to treat that first before I go on the injections. But it's a very extremely rare complications, 1 in 500 to 1 in 1,000. And more so in patients who already have risk factors for pancreatitis as such.
So we have time for one final questions. One final question. Questions keep pouring in actually, but for the sake of time,
no
what do you advise? How often would you follow up a patient who you start on Foundayo?
So generally, after starting the Foundayo, 1 month, because we need to see how the person is doing with the drug. Because if they're totally naive for the GLP-1s, it's important to catch up with them in a month. That will also give you a chance to dose escalation, depending upon the patient profile. And after that, you can see them after 3 months, or if the patient develops any issues or side effects. So you could give them another 2 or 3 doses at 1 month when you see them, depending upon the patient clinical needs. But I would definitely see them at 1 month, and after that, 3 monthly follow-ups, once in 3 months.
Dr. Rao, thank you so much. I think the other questions, whoever has any questions, they can aim it to Lily at their booth, and I think they can pass it on to Dr. Rao to be answered in future activities. Thank you so much, Dr. Rao. It was very engaging and a great presentation. Thank you so much, everyone. And I would invite you to go on to our next session, session 9, obesity, which should start any minute now. Thank you so much.
Thank you.
I will just stick to the commonalities. So this is not just about weight loss advice, because we do know that giving advice alone without anything else to back it up is pretty much useless in management of obesity. So this is an old slide from years ago, and you will see that if you restrict calories to varying extents, with or without pharmacological intervention or exercise, you can lose weight, but then not necessarily impressive amounts of weight. And that is all pre-GLP-1. Now, at this stage, it's important to stress that language and stigma matter. And this is underappreciated. So in the UK, there is an all-party parliamentary group on obesity which looked into this. And an overwhelming majority of people with obesity feel that they have been stigmatized, criticized, or abused. And this is not a lifestyle choice. This is not something as a failure, lack of discipline. And again, vast proportion of people believe that there's not enough understanding among the public, but also the politicians that we elect and the system in general. I don't think the situation is any different in the Middle East. This is a survey in Saudi Arabia, and let's not quibble about the statistics, but it would be fair to think that a sizable proportion of people with weight management issues feel ostracized and stigmatized. So in Canadian guidelines, for example, there's an explicit mention. The first step is to ask permission before talking about weight. You can't manage this complex condition for a patient without involving the patient and getting their buy-in at any stage. Then you can talk about assessing, advising, and assisting. So the concept of BMI has changed. So that goes back over 30 years ago. But we have framed obesity in terms of body measurements. And while that is helpful in quantifying the condition or setting thresholds for treatments and intervention, it is not the only or predominant feature. So if you take this YY paradox, for example, these are two Indian physicians, Dr. Yutkin on the left-hand panel and Dr. Yatnik on the right-hand panel. They have identical body mass index. However, the one on the left has got a body mass index, body fat of 9.1% when measured with the DEXA machine, and because he's a marathon runner. The other one with an identical body mass index has got a body fat of 21% because the only exercise he does is trying to raise to the doors of the lift before it closes. To illustrate that kind of biodiversity, I recently saw a patient with a body mass index of 73. She's only 39, and she has mechanical problems with, say, arthritis. She has to walk with a frame. However, she does not have diabetes. She managed to get pregnant, and with a body mass index of 73. And this was terminated because of the risks of carrying pregnancy to term, and she went into depression. So it's a great variation in individuals. So not two people with weight issues are quite the same. And it's helpful to frame it in a staging system. So this is a Canadian system taking into account the effect of obesity on medical, mental, and functional, from no effect to end-stage disease with gradations in between. And that's helpful because if you look at survival, well, people with overweight or obesity will have reduced survival, but the differentiation between different classes is much more pronounced with the Edmonton system compared to BMI alone. So this is what people are interested about, and this is certainly what the patients are interested about. So in the old days, the pharmacological interventions do work, but they don't work as much as surgical interventions. But then again, not everybody should or could have surgery. And but they start to change now. We've got very potent medical treatments which are approaching surgical efficacy, at least in the short term. So the liraglutide, which is now, over 10 years ago, opened the door, and by today's measures, this is not as dramatic as what we're looking now. But then again, even then, 15% weight loss occurred in a significant number of people. Keep looking at that kind of figure. 1 weekly semaglutide will give more than 15% weight loss in nearly half the people, and a third will get more than 20% weight loss. So that's semaglutide, and that is sustained over a period. And likewise for tirzepatide. So if you look at this, 20% weight loss, nearly 2/3 will get that at a higher dose, and about 40% will give more than 25% weight loss. So getting weight loss in the short term with GLP-1 agents or GLP combinations it's an established phenomenon, and it's widespread. In the Middle East, there's widespread access to those medications, and it is understandable that patients and clinicians are excited about that. There are different mechanisms, and we're beginning to understand different ways of how these work. But there are also problems as well. So the weight loss that you get is largely fat, but about as much as a third would be muscle as well. And that could become a problem. I won't labor through drugs under different development, and encouragingly, there are lots of drugs around. What we are now looking for is not just weight loss, but good quality weight loss. So weight loss from visceral fat, as opposed to generalized weight loss. The aim of preserving muscle will remain elusive at the moment. And the ease of medication and adherence, changing from injectables to oral medications or monthly injections, the horizon is quite exciting. So if you have those very different and very effective drugs, how do you choose? Well, like everything else in medicine, you choose according to what the patient needs. We know that obesity shortens your life expectancy, and that even losing about 5 to 10% modestly will have significant tangible gains in the comorbidity. So if you, depending on the outcome and depending on what the patient has and what it matters to the patient, there are emerging evidence of tirzepatide, semaglutide on prediabetes, diabetes, cardiovascular disease, heart failure. They are broadly similar. Semaglutide will have a bit more data on on chronic kidney disease. Tirzepatide has better data on reducing apnea-hypopnea index in sleep apnea. However, things will emerge, evidence will emerge, and the new drugs will have different profiles as well. But that treating short-term is easy. The difficulty is long-term. So when I was in training about 20 years ago, my trainer said, you take somebody into an obesity clinic and 5 years later on, they will be wherever they started from. And that's remained broadly true. And we see that alarmingly, if you take semaglutide for a while and stop it, the weight goes back. The same with tirzepatide. You continue tirzepatide, weight stays down. You stop tirzepatide, weight comes back. So there are longer longitudinal data now to say that these medications can maintain weight. But then if you are looking at childhood obesity in the Middle East and you've got a 25-year-old, how long are you going to continue those medications for if you're relying solely on this? And what is the safety of, not alone the affordability or economic cost of that approach? And that's because weight management is a complex issue. It is, at one level, an energy imbalance problem, but there are so many different factors. And that include individual factors such as activity, psychology, food consumption, behavior, but also societal issues like processed food, food production, social media, peer pressure, biology, and the general sedentary lifestyle that we lead in more prosperous societies. And there will be no one single, one-size-fits-all solution, and GLP-1s are certainly not that solution. So equity remains a problem. Now, perhaps less so in the Middle East, with increasing prosperity, where access to care and access to treatments is easier. But even within individual countries, there are huge variations in there. So I work in the northeast of England, where social deprivation is quite prevalent. You've got the same national guidelines, but depending on authority area, who can get treatment, at what stage, and what level of support is highly variable. And that must be true of any developed or developing countries. And this is probably beyond the scope of the group that are gathered here today. We are individual clinicians, so we can influence, but we cannot dictate on what happens to the wider society. And it comes back to the individual that you are looking after. You need to speak the language of the people that you're looking after, need to know their idea, their expectations, and their preferences, and frame it in a way that would relate to them. Without that, we will be doomed to failure. So I wish that I could summarize the guidelines very easily and say, this is what should be done, that is what you need to do, and this is what you will be doing. But that, of course, will be the wrong approach and will never succeed. So with that in mind, I will thank you very much for your attention, and I look forward to answering your questions at the end of the session. Thank you.
Thank you. Can you go to the next slide? So I'm honored to present Dr. Muhammad Saleh Ahmad. He's a consultant endocrinologist specialized in diabetes endocrinology and endocrine disease. He's going to be my buddy, so we'll be working together soon. He have long experience practice in the UK, and then moved to Dubai. Focus on weight management, diabetes, and other endocrine disorder. We're going to present a lecture on scalpel and the needle, obesity treatment barrier and outcome. The floor is yours.
Good afternoon, everybody. Thanks, Jalal, for this nice introduction. I hope you can hear me well. Now, I have used a sexy title just to attract your attention. Are we going for surgery or are we going for the medications as an approach to our patients with obesity now? But in fact, it's an integrated obesity management era when therapeutic convergence is moving past the binary of surgery versus medicine towards an integrated phenotype-driven framework for chronic obesity. I don't have any disclosures. So the agenda for this talk is going to look at the evolving landscape, which is from episodic care to stratified phenotype-driven obesity management. Then we look at 10 years cardiovascular outcomes and 2 years cost comparison, because this is a key factor, as been mentioned by my colleague on the last presentation. And then we looked at safety profile, chronic treatment dynamics, and phenotype-based decisions. And then we look at the main physiological impact, which is non-fat mass weight loss and how to manage this. And then we summarize at the end. And before that, we look at the treatment in practice, how to move on with the current evidence towards our goals. So obesity is a costly global burden epidemic. with more than 39% of adults have a degree of obesity. Complications is a big issue, either metabolic or non-metabolic. And we need to think about it in a different way, similar to hypertension, diabetes, or any other chronic illness. If you stop treatment, you get the disease back. And we need to consider moving on, because behavioral therapy alone with a dietitian session and a psychologist session is only giving us about 3 to 5% weight loss, which is insufficient for meaningful cardiometabolic improvement in many patients. So the era of pharmacotherapy is there. Now, looking at the evolving landscape, we used to look at it in the past as an episodic care, which focused on lifestyle counseling with late-stage bariatric surgery reserved as a high-risk rescue option. This is not correct. We have limited pharmacological options in the past when significant weight loss was not practical. At the moment, we're looking at the efficacy leap, which is introducing of highly effective incretin pharmacotherapy as anti-obesity management alongside established minimally invasive metabolic surgery. And the future will be viewing obesity as a chronic, relapsing neurohormonal disease requiring complementary long-term tools. So the clinical question is no longer whether to treat obesity aggressively, but which modality to prioritize and for whom and when. So fortunately, we are having this wide range of very good medicines available in this country. And the mode of action is being discussed in the last session, so we'll skip that. Recently, we have 2 oral GLP-1s, which is just being FDA approved, and they give around 12 to 15% of total weight loss. And we're having the injectable therapy, which has been going on for the last few years. But there are challenges related to these medicines that 50 to 75% of the patients, when they discontinue therapy, they get their weight loss back on at a maximum of 1.7 a year. And also the cost implication and the cold chain movement of these injections and the storage problems, and also the injection phobia, although this has been sorted partially by introducing of effective oral GLP-based medications. So if we look at the weight loss spectrum, comparing the current used medications, widely used medications, compared to metabolic surgery, we see that the modern dual agonist pharmacotherapy, which is tirzepatide, has substantially narrowed the historical efficacy gap, encroaching on what was once exclusively surgical by getting up to 20 to 25% weight loss in these patients. However, still, surgeries like Roux-en-Y gastric bypass is giving us around 31.5%. Recently, the ESO 2026 framework put some guidelines of pharmacological treatment for obesity and its complications, and they look at the evidence-based algorithm for personalized obesity management using 62 randomized controlled trials and multidisciplinary expert panel living evidence framework. I'll just use one slide of this presentation, which is the treatment decision framework. And they have do what we do normally in our obesity MDT by 5 steps: patient assessment and medication matching. So mainly to look at step 1 to assess adiposity. I think that's what we do in clinics and in MDTs, and then identifying complications, what type of complications, and then review comorbidities. And then patient preference, and this is very important, discussing with the patients the guidelines and what we have and what's good for them, and then it's down to them because the goals and values of injection versus oral therapy, etc. Also, we need to discuss the cost, because mostly in this part of the world, it's not covered by insurance. And then we match medications. The most important part, which is new in these guidelines, is they have called the sick fat, which is metabolic adiposity, versus the mechanical adiposity, which is fat mass. And sick fat is linked to changed endocrine and immune response from dysfunctional adipose tissue, and then complications like type 2 diabetes, cardiovascular disease, heart failure, and the most emerging MASLD. And the preferred here is terzepatide, because it has got superior metabolic, or semaglutide, while discussing the fat mass is to link to related physical forces from excess body weight, like sleep apnea, osteoarthritis, back pain. And here semaglutide has got a broader evidence. Terzepatide comes next. So for the mixed presentation, both metabolic and mechanical, they have recommended terzepatide comprehensive or semaglutide on broad benefits. Recently, the company which is manufacturing this molecule, retatrutide, which is triple therapy, has published phase 3 trial, which is called TRUMPH-1 trial. And the additive on top of the terzepatide is the glucagon receptor, which is mainly controlling the energy expenditure and lipolysis part, while the benefits of GLP-1 and GIP receptors is the same as before. What is new about this molecule? That all doses, which is 4, 9, and 12 milligrams, met the primary and key secondary endpoints. 4 milligram dose itself, which is one escalation from 0 with single escalation, achieved 19% weight loss. And the 12 milligram dose approaching the bariatric surgery outcome, and also subtracted weight loss 16.8% to 26.1%. So this is a medicine which is probably, I'm sorry. Can you see my presentation? Yeah. So this is a medicine which is approaching the effect which we see bariatric surgery. And also showed good waist circumference reduction. And this is the main factor, as you know, for sorting out the metabolic complications of obesity. I'll pass this point and I'll go to approaching bariatric surgery level outcomes with this medicine, as mentioned in the first slide, as good as 25 to 30% compared to other bariatric surgery modalities, which is sleeve and gastric band. Now, looking at the clinical and economical evidence, we look at 10 years cardiovascular outcomes because we have the old medicines now, the old GLP-1s, which is more than 10 years with us. And we look at the 2 years cost comparison across the new therapies as well. So comparing the old GLP-1s, the blockbusters, absolute risk reduction favoring surgery by 8.8%. I'm sure if we repeat this in the future, we'll see different results. It might be near the effect of surgery or superior to that. And the microvascular protection, the MACE event curves separates in favor of surgery by year 1. The nephropathy curves separate sharply by year 2, and profound metabolic improvements protect the kidneys. All-cause mortality is around 9% versus 12.4% with the old GLP-1s. And if you look at the economic reality, by using GLP-1, this is 2 years data, so it's including the new newer therapies, comparing to bariatric surgery, we are seeing healthcare utilization under surgery 37% for reduction of in ER visits, 21% on reduction in inpatients admissions, and cost savings with surgery over 2 years is around $11.689 $1,000. So the note higher chronic pharmacy costs drive the expenses of medical therapy, and surgery still delivers clinical outcomes at a lower total healthcare cost over 2 years. So this has to be taken when it comes to cost implications. Now, we look at the physiological impact, which is mainly non-fat mass loss. Obviously, it's more with surgery, less with GLP-1s, but it's still significant with GLP-1s. These body composition change after bariatric surgery or treatment with GLP-1 receptor agonist data, which has been recently published in JAMA Network. And how to get around this? That's the most important question. I think this is probably the main question which our colleagues in surgery are asking us as well as patients. Now, if you look at the weight loss post-surgery, it's not exclusively fat, as we say. Aggressive management of muscle preservation is essential, and you cannot wait for a long time because 55% of total 12 months non-fat mass loss, which is around minus 4.45 kilograms, occur within the first 3 months. So interventions within the first 3 months is a key here. And we cannot wait for the patients to recover fully from surgery. We need to interfere within the first 3 months because this is a very important window for our preservation of non-fat mass loss. And also, this is applying to patients who are on GLP-based medications. Now, when we take treatment in practice forward, looking at the chronic treatment dynamics, because of the sake of time, I will just mention this briefly. First of all, you have to add exercise, protein. You need to add address behavioral gaps, and then consider the weight regain, especially with GLP-1s and also with surgery at a late stage. There is a clear evidence by these interventions across all studies which has been done on GLP-based medications and also in surgery, you will get better outcomes. Now, the question of the chronic nature of pharmacotherapy, if you stop them, it's weight regain, how to address that. I know to reduce the cost, some of us are asking the patients to take a lower dose of GLP-1s, GLP-based medications, or asking the patient to take a spaced dose of these medications, which by the end of the day might give you a less cost when you use these medications. However, it's not all about that. Weight regain is not only about weight, the implication of weight regain. There's also other implications like cardiometabolic reversal, increased cardiovascular risk, physical function decline, and psychological burden after losing weight. Weight comes back again. Now, what is the evidence apart from spacing these doses or reducing the dose in the long term? Introducing oral therapies is probably going to be the solution by stopping GLP-1 injectable therapy at some point or GLP-based medications. There is a recent evidence from the ATTAIN-MAINTAIN trial when using the molecule oral orforglipron after stopping the tirzepatide or semaglutide, we managed to maintain the weight loss which we have attained on the long term, and also the metabolic benefits which we have gained with the patients during the weight loss journey with semaglutide and tirzepatide. There's a similar study which was done on and with similar results, which was with the oral semaglutide tablets as well. So the next step, which is a phenotype-based decision-making. Now, looking at what we discussed now, we'd like to take this forward into practice. Medications varies for patients who have got BMI of 30 to 39 without advanced diabetes. Patient prefer non-operative care, demonstrates willingness for chronic adherence, and maybe they can pay for the medicine on the long term when it's not covered by insurance, and lower immediate risk profile. Surgery fails when there's severe obesity with long-standing type 2 diabetes, probably adding MSLD here as well with advanced disease MSLD. Escalating insulin needs when patients are requiring insulin, highest probability of durable remission, metabolic syndrome dominance. Targeted medical, which we have discussed on the ASO guidelines, which when established cardiovascular disease without diabetes, utilize semaglutide based on select trial mass reduction data, especially for semaglutide because there is more evidence on that one, and cardioprotective priority over weight loss. Maybe bridging sequential when using extreme BMI or high operative risk, medical therapy first to reduce surgical risk, followed by definitive operative intervention. And this is probably what we do most of the time, and considering GLP as a bridge to safer surgery. Now, both medical intervention or surgical intervention have got its burden. They are not without complications. They are not without problems. And this has to be discussed with the patient clearly, including the financial implications of both modalities. And we have to be very clear when we come about a weight loss journey, or either in the future when we use a dynamic approach to these patients, we start with a management plan, then rediscuss the new management plan depending on the patient needs. There is an adding benefits from GLP-1 on patients who had previous bariatric surgery. We have a meta-analysis which looked at liraglutide when it amplifies weight loss, and we have seen reasonable additive liraglutide benefits when adding it to bariatric surgery, especially when the patients start to have this phase when they start to have a little bit of weight regain, maybe after 2 years of surgery. So to summarize, our approach to obesity management is to be redefined. It's complementary, not adversarial when we look at GLP-1 versus surgery. The phenotype-driven selection is very important. That treatment is dictated by disease severity, metabolic profile, and patient's readiness, not by clinical tribalism or one-size-fits-all protocols. And then we have to have the chronic disease mindset, both the physicians or the MDT and the patients when we are approaching obesity. Thank you very much.
Thank you very much for this excellent talk. I can tell you there is a lot of questions, so we'll wait till the end. I'm honored to present Dr. Ahmed Al-Sharifi. He's a UK-trained consultant in endocrinology with more focus on obesity management and reproductive endocrinology. He's also RCP examiner, so I think they have to listen to your questions because you may have it on the board. I'll start the floor with viewers.
Thank you very much for your introduction. I'm happy to be here. We are moving from obesity to what if we don't treat obesity, probably the next step would be pre-diabetes. So I'll be focusing on how do we approach pre-diabetes. Just taking the slides and moving. And disclaimer, this session is sponsored by Merck. Now, this is very useful analogy. If you look at type 2 diabetes, it is just the tip of the iceberg. Long before that, we may have the metabolic changes starting to cook up background. So you have the hyperinsulinemia, impaired glucose tolerance, impaired fasting glucose before the pre-diabetes. And this creates a very good opportunity and window to act and prevent type 2 diabetes from happening. Now, looking at the natural history of pre-diabetes and diabetes, it's clear that the onset of diabetes is preceded by maybe 5 or 10 years of metabolic changes. So when you go to the doctor and we say like 5.7%, 5.9%, you'll be reassured this is not diabetes. Actually, there are some changes happening at the pathophysiological and molecular level. The increase of insulin resistance that put extra pressure on the beta cell function, and also that causes hepatic dysfunction of insulin secretion, leading to increased fasting glucose, which we call it impaired fasting glucose, and also postprandial hyperglycemia. And this is the stage where the plasma glucose reaches around 100, between 100 and 125. This is what we call it the pre-diabetes, but actually we may see some changes, retinopathy, nephropathy, or some like 50% could have some complication which we don't know about because it's a state of asymptomatic. The metabolic stress at this stage leads to the pre-diabetes, which is a cardiometabolic syndrome, or what we can call it meta-obesity. And as I said, it's a good awareness about this time, it's a window to do some intervention at this stage. But people are different, some extreme variability in how people can progress. As we said, 5-10 years, you may have pre-diabetes and you may progress with diabetes, but that's very variable according to lifestyle, visceral fat, genetic component as well. So if we to define pre-diabetes, it's not just a number, it's a state of intermediate metabolic hyperglycemia, where the sugar number are not normal, but are not in the diabetes range. And it's characterized by the presence of the two important impaired fasting glucose, where the hepatic glucose production is impaired, and also the impaired glucose tolerance, which is the postprandial hyperglycemia, mostly related to insulin resistance and the glucose uptake by the muscle peripherally. This both leads to pre-diabetes and to diabetes eventually. So this is where we target when we say do lifestyle changes. Again, at diagnosis, the pathological process of type 2 diabetes is already well underway. There is already a beta cell deficit. There is already postprandial plasma glucose starting to rise up. So that's very important to do something about it currently, otherwise type 2 diabetes will happen. And you can see that some microvascular complication or macrovascular complication at a small rate could be there, but in asymptomatic individual might not warrant somebody to go and seek help. Why it's important? Because the numbers are talking here. 400 million people worldwide have diabetes, and that number will increase to 470 million by 2030. The main problem is awareness. More than 80%, they don't know they have it, or they don't know they have any complication until they present with eye problem or nephropathy, or with a full blown up picture of diabetes. Looking at the Gulf region, the prevalence of prediabetes is increasing, probably related to sedentary lifestyle, to increasing rates of obesity, could be to some family history or genetics, and you can see that the numbers are quite high, and that's an alarming sign. Individuals with prediabetes, of course, they are at risk of progression to type 2 diabetes. 5 to 10% individuals with prediabetes could develop diabetes annually. And 70% are expected to develop diabetes within 10 years. That's why early picking up of impaired fasting glucose and IGT could prevent us from moving towards the full blown up diabetes. As we said, there is some complication could happen with prediabetes. It's not only you have diabetes, you have to see your doctor annually and do your eyes and feet check. In the prediabetes state, it's already something is happening. Retinopathy was found to be in 8% of individuals with prediabetes. You could have some neuropathic changes into 13 and 11% of people with IGT and IGF, and sometimes 70% could have some degree of nephropathy, and the prevalence of chronic kidney disease could increase in people with prediabetes compared to diabetes. But why this is happening? Better to look at what's happening in the pancreas itself. In the euglycemic state, the first picture on the left, you can see this green fluorescent color. This is the insulin produced by the beta cell. So in a euglycemic state, pancreas is healthy, The beta cells are well functioning, producing insulin as usual. When you give them more hyperglycemia, you can see the color is going fainting and fainting. And this is the production of insulin going down. And in severe hyperglycemia, you can barely see any green color. And what happens is the beta cell lose their function, and it de-differentiate to alpha cell, which is the progenitor cell. And what can contribute is they producing glucagon instead of insulin, and that worsens hyperglycemia. So progression from euglycemia to hyperglycemia affect beta cell reserve and could cause the beta cell de-differentiation. Like, how do we prevent that? A couple of mechanisms which we could do to prevent this stage. Simple things such as smoking reduction, this could reduce it by 50%. Changing dietary habits, lifestyle intervention, that could change and prevent prevention to prediabetes in 33%. The most impact is by weight loss. Losing 7 to 10% weight loss will cut the chance of type 2 diabetes to half. And you see from the previous even diabetes remission studies, weight loss and early calorie restriction could reverse diabetes at early stages. And of course, exercise could contribute as well by increasing the muscle uptake of glucose and reducing prediabetes. So among those lifestyle changes, the most impact is weight reduction. But if you look at somebody who has no excess weight and not obese, who has strong family history, if they are slim and have prediabetes, there is not much weight reduction, but we have other therapies and other arms to tackle. If you look at 23 years incidence of type 2 diabetes, this is a big study, the DAC-Wing Diabetes Prevention Study, looking at prevention. And the issue is there is some long-term sustainability. If you introduce lifestyle changes, you would improve the impaired glucose tolerance, and this could be sustainable up to 23 years. So the intervention you make could have sustainable effect, and that highlights the importance of early intervention. You look at the difference between the control group and between the intervention group. This goes all the way up to 23 years. Very impressive. Looking at the incidence of type 2 diabetes over 4 years in the Finnish diabetes prevention study, if you introduce dietary intervention, you are reducing the incidence of type 2 diabetes by 58%, which also highlights importance of diet improvement. Again, it's not about glucose and diet. The pre-diabetes could improve. The fasting glucose could improve, fasting insulin, and 2 hours postprandial glucose as well. That's mainly when you introduce dietary intervention, tackling the pre-diabetes, mainly focusing on carbohydrate and lowering carbohydrate intake. And that takes us to the next step. I mean, you tried lifestyle intervention, you're going with a diet, you're trying, but it's good to go back in history and talk about metformin therapy because our ancestors used metformin to treat diabetes. They didn't know it's metformin. When the patient come to me and very reluctant to start metformin, and they will prefer natural herbal substance and berberine, whatever, I would like to show them this slide and tell them, look, metformin is extracted originally from a natural substance, which is the French lilac. And then we have come up with a guanidine in 1918, but it was very toxic, so we couldn't use it. And it's up to 1957 where we have the glucophage in the form of metformin. So this medicine is actually, historically, if you go back in time, it is from natural sources, but it's purified, modified, and more safe to use. I mean, till now, we don't fully understand how metformin works. We know it affects the hepatic glucose reduced production by looking at the gut AMPK protein and reducing insulin secretion. Also, if you look at the periphery and the muscle, and it reduces insulin resistance and improves insulin sensitivity, and also have some impact on the gut to reduce absorption. And there is some evidence that it increases some GLP-1 receptor as well. GLP-1 secretion. The effect on the gut is amazing. You can look at increasing GLP-1 and some reduction of bile acid absorption. And also there is some evidence that it affects the gut microbiome, increased abundance of certain microbiome, which promote reduction of insulin resistance. But what more interestingly, recently there was a big study showing that even it play up in the brain, in the hypothalamus, affecting a protein called RAP1 protein. This RAP1 protein has been linked to increased glucose and giving you insulin resistance, and we find that metformin actually inhibits this protein, and that may be one of the mechanisms how it improves insulin sensitivity. So it's not about the muscle, it's not about fat cells, it's not about only the liver. It could also look at the neuron level and affect the brain handling of the glucose. Of course, when you look at the diabetes prevention program, over 3,000 individuals, lifestyle intervention improved the progression to diabetes, and also metformin by 31% as compared to placebo. Also, metformin prevent type 2 diabetes in the diabetes prevention program, especially for high-risk individuals. If you look at people with high obesity, women with history of gestational diabetes, those with high fasting glucose, and those young adults less than age of 60. And that's why you could consider in the high-risk individual not meeting target for diabetes, but sorry, the HbA1c target, certain individual could be benefit from introduction of metformin on top of lifestyle intervention as well. If you look at the diabetes prevention program outcome study, if you follow them up for 10 years, they can sustain the improvement. Lifestyle and metformin, it can be sustainable with the therapy, and you could maintain their long-term prevention of type 2 diabetes by introducing therapy early in the disease progress. Also, there's some data that weight loss is maintained a little bit by 2 kilograms for people who are on metformin. If you look at the lifestyle, it helps with the weight. However, it's back to the previous weight, or it can go up, but those who are on in metformin could maintain a little bit of degree of weight loss. So it's not a weight loss drug, but in certain individuals, it may help them to continue to maintain their low weight that they initially lost. If you look at the China diabetes prevention program, I'm just trying to see, is it coming? Yeah. Lifestyle intervention, if you combine it with metformin, you could get 17% reduction of progression to type 2 diabetes. And metformin has been found to prevent the beta cell dedifferentiation in the pancreatic cell, and could help preserve beta cell function. And also we talked about the weight. Looking at the big clinical trials, there is some great evidence for metformin in pre-diabetes, and that's why the American Diabetes Association guidance suggested that you can consider it for individuals with high risk in pre-diabetes state. Of course, the American Diabetes Society as well consider metformin on top of lifestyle intervention. And it's with the new coated form, it's easy to cause no problems in terms of side effects, especially with the slow release metformin, given the outer shield that could prevent the side effects. But beyond metformin, you have the lifestyle, you have anti-obesity medication, GLP-1 receptors, bariatric surgery, and other lifestyle interventions such as sleep optimization, smoking cessation. So overall, the pre-diabetes is a window for opportunity, not a diagnosis just to observe and wait till diabetes hits. Complication may be there already before you feel them, and the lifestyle intervention remains the cornerstone, but the most studied therapy, and which is cost-effective, cheap, accessible, is metformin therapy, which could be considered for certain individuals. But as the previous speaker said, it's individualized, early intervention, that's important. Phenotyping patients is very important, and we can approach patients with certain approach to prevent type 2 diabetes according to their phenotype. Thank you very much.
Thank you very much. I'm going to start. Can you hear me, guys?
Yes, we can. Yes. So if you can have
I'll start with the first question or two, and then Dr. Hila can take. And I look at the different questions. There's a lot. So I can start with Dr. Muhammad. So, I think it's more of a practical question. So you start a patient on treatment. Typically, is the common one is the GLP-1 candle-based therapy. You don't see 5% response in 2-3 months What do you do?
Well, looking at the current guidelines, when you look at these patients, you have to, first of all, see where we start from. Are they on the extreme metabolic side of obesity? Are they having a very high BMI? Or we still have time to try a different, possibly a combined therapy? And usually ask my patients if they are doing enough protein intake, if they are doing enough resistance exercise, because these also enhance the weight loss. Now, the next step would be obviously bariatric surgery if we feel that this patient is a candidate for bariatric surgery. If you look at the recent data of response to GLP-GIP combinations or GLP-1 alone, there is a 20% of patients on either side of the scale, some of the 15 to 20% hyper-responsive. There is around 15 to 20% who do not respond at all. And this is genetic, due to the genetic predisposition of GLP-1. Maybe this is something we do in the future. We check the genes before we start, some genes before we start therapy. So this is my approach. This is what I'm doing in the clinic.
Okay. Now, I'll move to Dr. Ahmad. So when do you look, how to say it? So if you start patient on a treatment, would you look at maximizing the treatment or go to combination? In a sense, do you continue to increase the dose? Let's say you started tirzepatide or semaglutide. Would you titrate the dose higher and higher or decide to go to combination? The same thing, for example, we do with lipid or diabetes. Sometimes we go to combination because we like it more, because typically there's less side effect and maybe more benefits.
Well, I think the most cost-effective way is to go with metformin therapy and put it to the highest dose and see if there's any benefit. A combination, I would probably consider it for type 2 diabetes with the evidence of SGLT2, or which has changed and we increased the algorithm. For pre-diabetes, I'll probably start with metformin therapy, which is easier and cost-effective, and also wait and then try to optimize things quite early in the disease process. So yeah, no threshold to use combination, but give some time for the metformin maximum therapy to see if it's effective or not.
And the other treatment they did the trial, like the TZD, the acarbose, do they have any place?
For pre-diabetes, I think there is some evidence, but I use it as an off-license use. I use metformin and then can go at GLP-1 if the weight is a big concern. But certain individuals who are intolerant to metformin, for example, we could try some other therapy. Acarbose is a bit old, I never use it, but maybe consider something like glitazone if there is some problem with the liver, or GLP-1 as well. But I think it's off-license use as a pre-diabetes, that the most studies focus on metformin therapy.
Okay, thank you. I'll leave it for Dr. Rahila.
Okay, thank you so much, Talal. Thank you so much for the audience being so interactive, and we have loads of questions, so we'll try and get through them. Dr. Mo, one question for you, that are there any better assessment tools clinically apart from the weight or the BMI that we can utilize in clinical practice and that can help us in assessing the patients with overweight and obesity, especially considering the different ethnicities that we have here?
Absolutely. Well, thank you very much for that question, Mo. So yes, BMI is a useful screening and service eligibility tool, but it's not a great tool at all for a standalone measure for risk. Many guidelines do recommend BMI thresholds, but there's also waist to height ratio to assess central adiposity, because not all fat is created equal. And central adiposity is the villain here. So going back to the case example that I cited with a lady of BMI of 70, the reason that she doesn't have metabolic complications of adiposity rather than just the mechanical components is her actual composition of central adiposities may not be quite the same. There are staging systems. So in the UK, there is King's obesity staging criteria for looking at comorbidities, and I mentioned about Edmonton. So it comes back down to the basic bottom line message is you move away from how heavy is the patient to what is adiposity doing to the patient.
Okay, brilliant. Yeah, so waist circumference and measuring the waist height ratio is another clinical tool that we can utilize very easily in our system, in our clinical practice. And taking it on from there, Dr. Mo, I just wanted to know, just like we use HbA1c for diabetes, when we are monitoring these patients who are living with obesity, apart from weight, is there anything else that we can utilize to monitor their progress, especially when they are pharmacotherapy or and even the bariatric surgery, to look apart from weight, any cardiometabolic outcomes, anything else that we can utilize in clinical?
Yes, that's a really good question, but it's very hard in practice to do that because you will have a weight management clinic, and when you see that, the patients and the clinicians focus on weight. I think there's a question about, are we over-focusing on weight? Yes, because that's what we do. However, we talked about comorbidities, and that it may be metabolic risk, there might be diabetes control, they may have other complications. One of the questions were about how do we manage older people? And yes, that's really hard because older people will have a lot of other things, diabetes, diabetic nephropathy, and yes, some of the drugs will have a benefit on that. Semaglutide will have data on renal, for example. However, that will also have effect on muscle loss. And how do you see the impact of it? If they lose muscle and sarcopenic, they might be at increased risk of falls, for example, and then they might end up having femoral neck fractures. So what will actually happen to the individual patient is very difficult to know. And also, who is going to be taking charge of that? Because even if you are minded to be holistic and you have the time and facility to do that, many of these things are fragmented, and within the time that we have with our clinic rooms, it's difficult to measure. So research study will talk about weight loss and we'll talk about adding other drugs, other modalities, but how do we actually manage that is a really difficult thing. So the short answer to your question is yes, we should, but I don't really know how to.
Okay, no, that's fair. I think the subject, this obesity, has been changing so quickly, and we have so much research in it. I think we are going to learn this in future as well. Moving on, Dr. Saleh, there's a question for you that you talked about weight regain even post-bariatric surgery in your talk. And are there any clinical factors that can predict which patient is going to regain weight and which patient is not going to?
I think the data available that the patients who did not have psychological assessment prior to surgery are more likely to have a weight regain, especially for those who have a non-Hungry scale eating pattern. And we see this more with the sleeve gastrectomy rather than Roux-en-Y gastric bypass. And this is a problem in the practice in this part of the world because we don't have the typical MDT, which Dr. Mo is having back in the UK, which I used to work with in such a setting, that we discuss all the patients prior to surgery and make sure that the patients who go through surgery are the patients who are ready for surgery. The second factor is possibly patients with genetic obesity. And again, if we feel that there's a patient who have got a monogenic obesity syndrome, which is likely going to help us which type of surgery to use, because in this type of patients, restrictive surgery and sleeve gastrectomy may not be of benefit. And in fact, sometimes even Roux-en-Y gastric bypass might not be of benefit. And there are actually new therapies which help with intervention in this type of patients. So some monoclonal antibodies have been developed recently. If there were time to talk about new therapies apart from GLP-1, GLP-based medications, I would have mentioned some few interventions there. But obviously, can I just say something here? Because I can see a question here, and it's very much related to this. What is one thing which we can change to improve our obesity?
Yes, I was going to ask that, yes.
Yeah, and I think it's related to this. I'm very clear about this, and I'm sure most of you who are working in this field are very clear about this. There is a fantastic research, fantastic medications, a lot of minimally invasive procedures, but who is covering this? Insurance companies, commissioners have to look at obesity in a different way. It's a preventive medicine. If you treat an obese patient, if you intervene earlier, you are actually looking at a better chronic disease model in the future when it comes to cost and pressure on the healthcare system, when it comes to the whole cost coverage. I think this has to be looked carefully, including orthopedic procedures, etc. And also cancer, which is not being mentioned today. Obesity is a leading cause of cancer, and we can reduce cancer prevalence by provoking weight loss in our obese population.
Thank you so much, Dr. Saleh. Coming back to you, Ahmed. You talked about pre-diabetes, and the audience would like to know that if a patient has obesity and pre-diabetes, is it reversible? How early we should consider the pharmacotherapy, for example, metformin, or we need to consider quite early the weight loss medications? And the second part of the question is, can lifestyle intervention, is it a part of the treatment, or are you going to talk quickly about it? So over to you, Ahmed.
Thank you very much. I would probably, the first corner of treatment, it will be lifestyle intervention, because that could reverse things. And I'll give it some time to see if the lifestyle, we should agree on a target with the patient and see how is that achievable and sustainable. We talk about what to improve on and how to change the lifestyle. We set a target, maybe 6 months or so, to achieve those targets, and then we can add on therapy to prevent that. Therapy could be GLP-1, of course, because there's very good evidence data that they prevent diabetes from progressing. It could be just that, on addition to lifestyle intervention. However, it's an individualized decision, I think, with the patient. Depend on their lifestyle. Sometimes lifestyle would not be very sustainable, as it's not practical given the patient's comorbidities, for example, and that's why we may move to the therapies earlier. So I think it depends on assessing the patient and discussing what's the best in their best interest.
Okay, thank you so much for that. And is there a role of CGMS in pre-diabetes then?
Sorry, can you repeat that again?
Is there a role of CGMS, the sensors to monitor the blood glucose in the care in pre-diabetes?
Yeah, I think it's very interesting. I think it is, I mean, of course, insurance won't approve that for pre-diabetes. However, having an insight about the sugar and daily fluctuation will be very useful. Some patients will know exactly what diet to upset their glucose by having a CGM trial. I think it's an eye-opener for some patients. If you give them CGM and ask them to have a look at that. So maybe they could make better choices with lifestyle, or they know what's happening in their sugar by having a CGM. So I think there is a big role, and I really like it. However, of course, it depends on the patient. Some will not want extra anxiety about what the sugar happens, so we don't give it. But I think it should be a good thing to consider, especially for those who want to make an active changes in their lifestyle.
Thank you so much to all my speakers.
Can I add a point, Dr. Rahila? Yeah, that this session was the slides were my slides. So when I'm talking about therapy, this is my individual take on it, and this is not like a sponsored presentation. The evidence comes from many trials. Lifestyle remains the first line. Yes, you can consider additional therapies, depends on the situation.
Thank you so much to all the speakers and for the audience for being so interactive. We are going to finish the session here, but the key take-home message from the obesity session is it's a chronic, recurring and relapsing disease, and you need to have that long-term relationship with the patient, and do think of individualized approach where the patient needs lifestyle intervention, pharmacotherapy, or metabolic bariatric surgery. You can now join the next session, which is actually on medical management, including GLP-1 oral Wegovy pill. So you can hear Dr. Jalal Nafsh on that. Thank you so much, everyone.
Dr. Jalal, I'm going to go over the Wegovy pill, which is a breakthrough, a new addition to the agents we have to help with weight loss. I've been engaged by Novo Nordisk to give this lecture. So the question is, what are we going to review in this lecture? First is why we need to look at oral weight management solution. We're going to touch on the OASIS trial program, which is the trial program for the Wegovy tablet. And then talking about the benefit of Wegovy, going over data from Optic and Orion trial. So it's not an unknown fact that obesity or overweight is quite prevalent. Most of the places may run 60-70% prevalence among adults. Now, when we're looking at worldwide, there is estimated in 2015 about 1.2 billion with a B number of patients who will have obesity or overweight. And again, this is assuming the overweight start at BMI of 25. Of course, in Asian population, you may need to start at a lower BMI. But it's the expectation by 2030, which is again 3.5 from now years, expected to grow to about 2.9 billion. And what we know that when we try to fight obesity, it's always been quite a trouble for patients, because as they start to lose weight, there is increase in the hunger, there is decrease in satiety, and patients find it very hard and difficult to maintain any weight loss to achieve. We've been seeing more data and more benefit on using injectable GLP-1 that showed significant weight loss comparing to placebo. And so having an oral administration or a form where give a patient other choices and possibilities, as a lot of individuals may not like to do injection. And actually, I'm going to go show you some data on patient preferences. So when we look at semaglutide itself, why semaglutide? Well, semaglutide has a long-term, well-established safety program. You have over 38 million patient years. The number of patients on clinical trial who did receive it for obesity or type 2 diabetes, over 26,000. There have been many trials on using it as pre-diabetes. There is trials look at using it on patients with established cardiovascular disease without diabetes, and actually even with diabetes, of course. There have been treatment on looking at obesity-related HFpEF, renal impairment, treatment for MASH, and also helping patients with knee osteoarthritis. And that's been since 2018. Now, semaglutide is very similar to the human GLP-1 analog. There have been some amino acid substitution to go against the DPP-4 degradation. So the normal human GLP-1 have a half-life of 1 to 2 minutes. There's also an addition of a spacer with 18 carbon chain fatty acid, and that actually will help binding to albumin and prolong the half-life of the drug. And that's allow the ability to give the medication once a week if you give it as an injection, and also allow the ability to have a longer half-life in oral formulation. Now, what kind of benefit do we get if we're going to use Wegovy pill? And we're going to touch on a study called OASIS-4, which is the main trial looking at using Wegovy tablet at 25 milligram. The inclusion criteria is as any overweight trials, it's mainly including patients with BMI of 30 or above, or BMI 27 or above with one complication or more, such as hypertension, dyslipidemia, sleep apnea, or cardiovascular disease. Now, again, this did not include per se diabetic. Patients were started on placebo, oral semaglutide with titration up to 25 milligram. Both groups did go through a lifestyle intervention, which will include 500 calorie deficient a day, plus 150 of moderate physical activity, fast walking or so. And of course, it's trying to see, is this drug superior to placebo mainly? The primary endpoint was the change in the body weight and percentage change. And also there's multiple secondary outcomes we're going to touch on some. So when you look at the trials, again, there was more females in this trial. The mean BMI is 37. The mean weight is 114 centimeter. Systolic blood pressure 131/83. So what kind of benefit do we get when we compare to placebo? So mainly when you look at this trial, as you use and intensify the treatment and you increase the dose, you can see that patients continue to lose weight. And you can see that still till now, there's no plateau in the weight loss, as it seems. Up to 64 weeks, there was almost 17% weight loss. There is 2.7% weight loss in the placebo. The difference between the two arms is 14%, which of course was quite statistically significant. Now, the second thing is, how do I relate this in a sense, saying how much percent of patients achieve 5% weight loss? And the answer is almost 90%. So when a patient comes to you, you're going to kind of present to them the data and say, this is the average weight loss. And of course, not everybody loses the same amount of weight. Some patients lose more, some patients lose less. It's hard to predict the response easy. So you need to treat the patient. The weight loss has no relation to side effects, so you can get nausea or not, and still you may lose weight. But again, you're going to tell the patient that you have almost 90% chance you're going to lose at least 5%. You have 70% chance you're going to lose 10%, so somebody who's 100 will become 90. And you have 1 in 3 chance that you're going to lose 20%. And that's quite significant, so which means that if an individual comes to you with a weight of 100 kilogram or 110, typically you're going to expect them to drop 20 to 22 kilograms down to, from 100 to 80 or 110 to maybe 88. And that's the average weight loss. Now, of course, some patients lose more, some patients lose less, but this is kind of the data we're going to get. So when a patient comes to you, you're going to say that typically the standard draw is about 17%. Now, again, there is a tool that you can use called Wegovy that actually can track your progress. And when they try to look at the data, when patients do track their progress, actually they lose more weight. You lose maybe 21, 22%. So it'll be nice to enroll where you can track the change in the weight and not just take the pill and don't do anything else. And that will improve your odds to lose weight. But there's another data that's important, is try to see the early responders or not. So here they try to do post-hoc analysis and say, if you lose 10% or more in the first 16 weeks, so mainly first 4 months, typically you're going to lose about 22%. And if you're not one of those high responders, so typically you're going to lose maybe 5 to 7%, then typically your weight loss at 64 weeks is 11.5%. So by 4 months of treatment, if a patient comes to you and they already lost 10% or more, you're going to tell them very likely you're going to lose an additional 10% or 12% to go to about 22%. So you have a way kind of predict from the early response phase. Now, what's about tolerability? Do we have any side effect? And of course, if you try to plot it against placebo, and on the left side, you can see the overall adverse event, and you can see really they're a little bit more, but even placebo, 85% of patients taking placebo had a complaint or have adverse event. GI side effect, of course, more pronounced, 74 versus 42. Now, adverse event leading to discontinuation, there's only a difference of 1%, 6.9% versus 5.9%. So even placebo patients did complain of GI and discontinued the treatment. And when you look at GI adverse event leading to discontinuation is only 3.4% versus 2%. So mainly 1 of 30 patients will discontinue from side effect and 1 of 50 patients in placebo. Now, serious adverse event actually lower. So mainly hospitalization and so was lower in the group receiving Wegovy tablets. Now, all the tablets the same. And here I'm going to show you data. And again, you have to understand this is not a head-to-head study. So the first one is called Orion, which is an indirect treatment comparison, trying to look at the 2 studies and the 2 population and analyze that if I have a comparable population, what's the expected response and what's the difference in the response in the oral semaglutide versus oral orforglipron. And again, you can see the study on the OASIS-4 with the oral semaglutide and the ATTAIN one with the orforglipron. Now you can see here the dose on orforglipron at 36 milligram, which is the older formulation. Now it's a different dosage. But again, there is a little bit of variability in the percentage on the female, but typically speaking, the inclusion criteria is the same, but again, it's not exactly the same population, and that's the idea of this analysis. And when you try to see the difference in the weight loss, do I see a difference if I analyze the population? And when you see that, if we analyze the data on the 2 population, we expect that if I'm going to use oral sema on the same population as orforglipron, I'm going to expect maybe another 3% weight loss additional when I'm using oral semaglutide 25 milligram. Now, the other part is the side effect. And so when you try to analyze the data or the discontinuation related to adverse event, the odd ratio is in favor of oral semaglutide for about 4-1. Now, treatment discontinuation due to GI side effect, the odd ratio is much higher, but the interval is quite wide, 2 to 96. So I will look more at the treatment discontinuation due to adverse event. And so when you try to summarize the data, what shows that, again, this is not a head-to-head trial, but there is expected 3% additional weight loss if you use oral semaglutide 25 milligram versus the orforglipron. There was more adverse event and discontinuation compared to the oral semaglutide. Now, the other data I'll show you, which is the OPTIC, it's not really a head-to-head trial. It's mainly analysis where you're trying to include patient, try to get patient insight, and try to see how much are they aware of their obesity, how much aware are about the agents available for weight loss, and what they prefer. So mainly you're going to give them two, theoretical drugs. Again, it was not theoretical. They actually give them the data on the two medication, and they present that data to the patient, and they will say, what do you prefer of the two choices, and so on. And so mainly they presented two treatments. So they said, we have one treatment, which is treatment A, and they said that you're going to have about 30% of the patient who's going to lose about 20% of the weight versus their 18%. You're going to say that there's treatment A, which is in this case is, again, they do not mention the brand, of course, that we have a data in cardiovascular protection. Still, we don't have data on orforglipron. And then they said, it's once daily for both of them. Then they indicated the drug interaction, and then the percentage of patients who may discontinue treatment, which is 7% versus 10%. And when you try to analyze that data, what you see that what actually surprising for me is the fact that a lot of patients who never took any treatment for weight loss, or 70% of them mainly, are open to take treatment. So I think a lot of time, the problem with obesity is a lot of time we as a physician will see the patient being overweight. We don't say anything because we don't want to say anything that may sound bad. And then even if we'll try to do, lifestyle intervention. And then, only maybe 5% of patient or 8% of the patient will actually end up by taking medication. The majority, they don't take any treatment. Now, what the data here shows that actually 7 out of 10 patients actually willing to treat the obesity if this was offered to them. When they tried to give the two profiles from the medication, 84% of the patients did like the profile of the oral semaglutide. They did not find the dosing condition disruptive in a sense that you need to take it with a little bit of water and wait at least 30 minutes. And then when you try to see is, do you really prefer tablet or weekly injection? 2/3 of the patient would prefer a pill over weekly injection. Now, again, this is individualized. There's 80% of the patient will prefer a daily pill versus weekly needle syringe. And then they will prefer tablet at any shape versus pen or vials, respectively. So patients seems to prefer tablets in this trial or this cohort. And when they offered the profile of the two products, they were more likely to prefer the oral semaglutide. Now, how do you start? Well, typically speaking, again, you have to follow the guidelines, which again, it's anti-obesity agent. So typically you start patient with BMI of 30 or above, or BMI 27 or more, in the presence of at least one obesity-related comorbidities, as we mentioned, prediabetes, diabetes, of course, hypertension, dyslipidemia, obstructive sleep apnea, cardiovascular disease. And the second indication is, of course, to reduce the risk of major cardiovascular event, which is cardiovascular death, non-fatal MI, non-fatal stroke, in adults with established cardiovascular disease and either obesity or overweight. And again, that's based on the SELECT trial, which is looking at obesity with established disease. Now, if you have a patient who's taking injectable Wegovy, how do we go to tablets? So if a patient taking 2.4 milligram, typically what you do is you start the oral semaglutide a week after the last injection. So if, let's say, they injected the last injection of Wegovy 2.4 at July 1, you start July 8 with the tablet, and again, you follow the recommendation, and you start directly 25 milligram. Now, the other way that if a patient taking tablet and go into injection, and then again, this is a US level only, so of course you can switch as the same agent anyway. So what you do is you discontinue the tablet and you start the injection once weekly. And if they have a problem of not tolerating the 25 milligram tablet, you can switch them to the Wegovy 1.7 milligram. Now, the way to titrate, you start patient the first month or 1.5 milligram. And again, this is a new formulation, so lower dose, but the same pharmacodynamic. Then the second month, you go to 4 milligram. Then in the third month, you can go to 9 milligram. And then after this, you can push to 25 milligram, which is the approved maximum dose. So within 4 months, you get the response or the titration. And typically by 120 days is we can actually see kind of an idea what the patient's doing. And again, you already have the data that showed you that if those population, mainly after 30 days of being on 25 lost 10%, you expect another 10-12% response, maybe more. Because you have to remember the study stopped at 64 weeks. If they lost 5, 6, 7%, you're going to expect another maybe 7%. So, you know, about the same amount by 64 weeks. So you'll have a kind of an idea of where the patient respond. And that will help you discuss the data with the patient because, you know, patient has to understand that whatever you do to try to lose weight, always the initial weight loss is faster and then it slows down. So that will give patient kind of predictability so they don't get frustrated and discontinue the treatment, of course, unnecessary. So how do you take the pill? Well, you wake up in the morning fasting. You take it with a little water, less than 120 ml, and you wait at least 30 minutes before you eat or drink any other pills or eat any food. One thing we have to remember that we need to make sure that the patient follow this recommendation because if they don't do it exactly, that could affect the absorption of the tablets. Now, at the end of the day, when you discuss the drug with the patient, you have to emphasize that, yes, I'm using it as obesity, but there's other benefit included with it. And that's the same thing that happened to me when I treat patients with diabetes. And I say, I'm going to use, for example, Rybelsus, or I'm going to use Ozempic. And they say, well, I don't want a medication for weight loss. And I say, this is not for weight loss. You are a high risk. I need to treat you as a high risk or you have established disease. And it reduced the risk of MACE. It reduced the risk of stroke. And this has no relation to your weight loss per se. And we know that already from the SELECT trial. So the cardiovascular benefit is not exactly related to the weight loss. So we have to explain to them that this is a weight loss drug, but it has an additional benefit that it did reduce the risk of mainly liver disease progression. And actually there was an improvement in the fibrosis and 63% resolution of the MASH. There was reduction in the MACE in the cardiovascular outcome trial. There's a reduction in the heart failure, mainly 70%, mainly 2 out of 3. There's improvement in kidney function as we've seen in the FLOW trials. And then again, we showed the data on the OASIS-4 with the 17% weight loss. And again, if you use Wegovy Care, which is a tool free available, and you can track your progress, actually, the average weight loss in this population is 21%. And so at the end of the day, I'm trying to show you a data on a drug that's been since 2018, that's been established. And all I'm trying to show is if we use it as an anti-obesity drug in a oral formulation, we are going to expect 17% weight loss. In the population who lose more in the first 4 months, we expect even more weight loss. And those who follow a tracking tool, you expect more weight loss. The drug has very well established safety. We have so many trials, there are 38 million patient years exposure. It has no clinical significant drug-drug interaction. When you compare again in indirect comparison, it showed more weight loss compared to the orforglipron with less chance of discontinuation. And I think at the end, we have to explain to the patient that this is not the obesity, it's the whole syndrome. It's the obesity, the cardiovascular disease, the risk of HFpEF, the risk of MASH and MASLD. And I'm targeting everything. And the benefit, including the heart benefit, the MACE benefit, and including even the liver benefit, is not 100% weight related. And I think I'll stop at this point and be ready for any question.
Thank you. Thank you so much, Dr. Jalal, again for a great talk. So we have many questions. I think we have 6 minutes for questions, so we can take a few. So first of all, how do you compare the dose with the injectables. So people are inclined to change from injection to tablet. So this is the $1 million question, really, because everyone wants to switch from injection to tablet. How would you manage that? And dosage mainly. I know it's still new in town, so maybe we don't have plenty of experience with it. But what would you advise, the general advice for now?
I mean, if they're already, I mean, you're not going to necessarily go back to the baseline dose, of course, of the GLP-1s. You're not going to start with the 1.5. So again, if somebody taking the Wegovy 2.4 as an injectable weekly, you go to the 25 daily, and that's it. And that will be it. So now, if you do the injection today, and next week after 7 days, you start the tablet. Vice versa, if you go from a pill to injection, then the next day you start the injection, and again, 2.4, 25. Now, if somebody did not tolerate the 2.4, you go to 1.7 on the injection, or I'll go to the, the lower dose, i.e. 9 milligram on the tablet. So that's kind of typically what I do. And of course, they need to have the education of how to take the pill or the water, and to try not to push themselves to overeat. I mean, this is one of the major problems, because people say, you know what, I'll go eat a burger. I mean, again, we have two kind of a hunger system. So we have survival, if you want to call it, and we have our human set of hunger that we see something we like to eat, and that's the part that sometimes you can overeat, and that causes more side effect of medication. On the trials, you see much less discontinuation maybe than the life you see in typical, because in the research, people are monitored, you contact them, you make sure they're well educated on what to eat and that. So I think that's really what's missing sometimes in our treatment beside the medication. For us as a physician, it's easy, we write medication and that's it. The problem is they need education on the diet, also on exercise. And I think this is what's missing. And I think part of it is also insurances in the private do not cover for any of that.
Okay, thanks so much. Another important question. So they ask you, why is the Wegovy pill in 4 doses? So why wasn't only the 25 milligrams, since Rybelsus had the 3, 7, and 14? So from their perspective, this can create confusion.
Yeah, it's the new formulation. I know. I mean, this was one of the, even in the slide I presented, I did not talk about it because I don't want to confuse. But again, they did the other dosage. And actually, this even applied for the orforglipron. The dosage available is not the initial dosage in the trial. So it's totally different. So the 36 milligram in the treatment trial, it's now what you have is 17.2. So it's a different formulation. That's the same pharmacodynamic blood level concentration exactly.
Okay, thanks so much. So one last question. Which patients would you put on the Wegovy injections, and which would you go for the tablets?
I'll present to the patient. You've seen the data on the optic. Now on the optic, you've seen a lot of patients prefer pill than injection. Now, if I was one of those people, I like injection myself, right? But so typically I give people choices. I don't tell them you have to take this pill. I tell them we have a pill formulation, we have injectable formulation. The response is almost the same. This is how you do it, this is how you do it. And, you see what patient preference. I have people cannot remember things weekly, and I have the other way around. And I have people who don't like injection. So yeah, I keep it open. It's not like you have two ways of
patient preference.
Oh yeah, it's not my preference. Now, saying that, if I have somebody, and this is me, Jalal, if I have somebody who did bariatric surgery, and again, this is kind of off-label because most of the weight loss trials don't look at bariatric patients. I prefer to use injection in bariatric because, I'm not sure if there's, and maybe there's a data, but I'm not aware of any data look at absorption of the tablet if you have a bariatric patient. So in those patients, I tell them, we don't have data, I prefer to use injection, but we still can use the tablet. And I have people post-bariatric that using the tablet, semaglutide, but again, but this is not a label thing.
So since there are so many questions, I said that the previous one was the last, but let's take one or two more. How would you define the treatment?
I see the question. Let me touch on two quickly. So number one, do not do ultrasound patient. I think there is a lot of misconception about thyroid. So the first thing you need to do, if you have a thyroid problem, that's not contraindication to take treatment, period. The only contraindication is family history of medullary thyroid cancer or personal history of medullary thyroid cancer, which mainly 1 in 40,000. It's very rare. Number two, you don't need to do an ultrasound for people unnecessary because that's creating a whole problem of over doing ultrasound, over biopsying, and doing unnecessary, surgeries. If there is a clinical indication to examine patient with ultrasound, please go ahead and do it, but don't do it just because they're taking semaglutide.
What about
I think
doing
the second part is the issue.
I see people doing calcitonin tests.
Of course not. Because, and again, the risk of medullary cancer is 1 in 40,000 about. Any test you do, there is a false positive. I don't know what the false positive in calcitonin, but I don't think it's less than 1 in 200. Even if 1 in 200, you're going to have 200 false positive for 1 true positive. You're going to have, and I've seen people who did unnecessary calcitonin, a little bit high, they did biopsy, and then they're stuck with this. So no need at all. The third issue is the issue of pancreatitis. So people with diabetes and obesity have a higher level of amylase lipase. And when you take GLP-1, the level goes higher, usually 20, 30%. So do not check amylase lipase because somebody said I'm a little bit queasy on the stomach, because you are going to likely have a high level, but that doesn't mean pancreatitis. So pancreatitis, as the way we learned in med school, patient go with severe abdominal pain, nausea, vomiting. Yeah, that is pancreatitis. But beside that, I think this is one of the major issue. People do blood test and they do amylase and it would be like 1.5 to normal. And they tell them it's pancreatitis. This is not. So you have to ask patient the questions. A lot of people who are kind of quote unquote misdiagnosis. Actually, in the tirzepatide trial, for example, there's, I think if I'm not wrong, 6% of patients have 3 times normal level. So you have to have a clinical reason to do the blood test, i.e. amylase lipase. You have to have a clinical reason to check calcitonin, and you have to have a clinical reason to do the ultrasound. Beside that, don't do it.
Just to add to, because this is very common in clinical practice, that sometimes patients are fine doing amylase lipase routinely, and then after whatever GLP-1, they become elevated with no symptoms, and then you're stuck. Should you continue or should you stop? And we don't know really. We don't know what this indicates clinically.
No, it doesn't mean anything, to be frank. Again, it goes up 20, 30%. I mentioned the data on tirzepatide. You're talking 3 times normal in about 5-7%, and those not pancreatitis. There is no diagnosis, in the ICD-10 called asymptomatic elevated amylase lipase. So there's pancreatitis and there's non-pancreatitis.
Thank you so much, Dr. Jalal. I know you're on vacation. You're the rest of your vacation. Yeah. Thank you so much for being with us. And I would, we have half an hour of lunch break, and at 3 p.m. we have Meet the RCP, which I would advise everyone to attend, followed by our social media session, which will be the last session of the conference. Thank you so much, Dr. Jalal. Thank you.
Thank you. Have a good one. Bye.
Glucophage XR, a right tool along the diabetes continuum. The Gel Shield diffusion system of Glucophage XR offers an extended absorption of metformin, permitting once daily dosing. Gel Shield technology of Glucophage XR and reformulation of metformin properties were patented in 2002 and 2004 respectively. The Gel Shield system is a biphasic, controlled release delivery system composed of an inner solid particulate phase and an outer solid continuous phase. For the Glucophage XR tablet, the inner matrix contains individual granules of a metformin-associated polymer. The outer matrix consists of a different polymer containing no metformin. Glucophage XR is laying on a non-effervescent floating tablet type. The swellable and gel-forming polymer is employed to achieve flotation and to extend the diffusion of metformin through the tablet matrix. Therefore, these two principles work in synergy for a more robust and reliable extended released dosage form. The Glucophage XR tablets have gastro-retentive properties. On the one hand, immediate release metformin has a narrow absorption window because it is mostly absorbed in the upper small intestine. Conversely, the gastro-retentive tablets such as Glucophage XR can stay in stomach and release metformin for. The Glucophage XR tablets have gastro-retentive properties. On the one hand, immediate release metformin has a narrow absorption window because it is mostly absorbed in the upper small intestine. Conversely, the gastro-retentive tablets such as Glucophage XR can stay in stomach and release metformin for 8 to 9 hours, being absorbed in the upper small intestine. An extended release metformin tablet using a different principle, like coated or osmotic pump, when administered, could pass through this narrow absorption window without releasing the right amount of metformin. Prolonged release of Glucophage XR can be demonstrated experimentally using 2 glasses of water. In one glass, we put an immediate release metformin tablet and a Glucophage XR tablet in the other. In a short period, the immediate release tablet will dissolve, while the Glucophage XR tablet swells and takes longer time to disperse. A significant proportion of patients may be unable to tolerate the conventional immediate release metformin due to gastrointestinal side effects, such as diarrhea. Glucophage XR as monotherapy offers 53% less gastrointestinal adverse events and 77% less diarrhea compared to the immediate release metformin. Glucophage XR was developed with the intention of enabling once-daily dosing of metformin and of improving its gastrointestinal tolerability. Over time, the disintegration of the hydrated polymer mass or its pliability enables it to pass through the pylorus, or it may be broken up by normal peristalsis in the gastrointestinal tract. The biological inert components of Glucophage XR occasionally remain intact during gastrointestinal transit and are eliminated in the feces as a soft hydrated mass. It is recommended that patients be advised that this is normal. Glucophage XR smooths the delivery of metformin into the bloodstream over the 24-hour dosing interval, while not affecting overall exposure to metformin. Glucophage XR, a right tool along the diabetes continuum.